Good morning. I, Latika Bajaj, welcome you all on the second day of virtual workshop of nursing management of patients with traumatic brain injury organized by National Institute of Nursing Education, PGIMER, Chandigarh. We are back with all the topics related to this traumatic brain injury, and I would like to start with the first talk of the today, that is the intracranial hypertension and brain herniation. Today's first topic is intracranial hypertension and brain herniation. Whenever we talk about heart, we always talk about blood pressure. But what about brain? What the best thing we have to assess when we ask about the brain? It's the intracranial hypertension. So what is intracranial hypertension? The intracranial pressure is the pressure which is exerted by the intracranial contents, which are created by the brain tissue, cerebrospinal fluid, and the blood. And the pressure against it, the wall of the cranium, it forms the intracranial pressure. If we talk about the normal range of the ICP, it is 0 to 10 mm of Hg, acceptable up to 15 mm of Hg among the adults and older children. It is 3 to 7 mm of mercury in young children and 1.5 to 6 mercury mm of Hg in full-term infants. Now, what is intracranial hypertension? Now, whenever it is normal, it is ICP, but when it exceeds the normal limit, it becomes the intracranial hypertension. So values higher than 20 to 25 mm of Hg is known as the intracranial hypertension, and it needs to be treated, and more than 40 mm of Hg, it can be immediate life-threatening situation. How ICP works? It works on a very simple principle, and that principle is known as the Monro-Cayley hypothesis. According to this theory, according to this principle, all the three components, that is the blood, CSF, and the tissue, remains in some balance. Now that balance will be maintained, but once any out of these three things, one volume increases, such as some injury is there, some tumor is there, if volume of any tissue or in blood will increase, the other two has to decrease themselves so that the balance will maintain. This is known as the compensated mechanism. But what happens when this compensated mechanism is lost? It becomes the decompensated, and that is the state when ICP starts rising. So body has some acceptable limit up to which it can control the intracranial pressure, but once it increases, it becomes the intracranial hypertension. So we can know that once it is increasing, the body will show its symptoms. And what are the most important symptoms? Headache, vomiting, blurring of vision, disorientation, lethargy, depressed consciousness or sometimes loss of consciousness, pupillary dysfunction, visual field deficits, changes in motor function, loss of brainstem reflexes. We have already talked about reflexes in the last session when we talked about Ms. Punita Sharma had clearly discussed about the brainstem reflexes, and most importantly, papilledema. It is a swollen of the optic nerve. Whenever we perform a fundoscopy, it is not always possible to detect it in the clinical settings, but whenever we have a chance to look into the fundus, we can see the difference of the normal and the abnormal visualization of the optic nerve. Now, this is the typical three triad of the increased ICP, where we can define it as a bradycardia. Bradycardia means it's the heart rate which is less than 60, irregular respiration, and widened pulse pressure. Pulse pressure means it's a difference between the systolic and diastolic blood pressure. Most importantly, it is increase in the systolic blood pressure. So these three symptoms are very typical features of the increased ICP. Now, in some settings we can monitor the intracranial pressure, and some settings it's not possible. So ICP monitoring is the management, could be a management for the severe traumatic brain injury, and it could be diagnostic also. Like we can also use ICP monitoring just to diagnose a patient, and sometimes it can be also useful to drain the increased ICP or increased CSF from the brain. There are the three mechanisms or three ways by which we can monitor. It's the subarachnoid bolt, epidural bolt, and the external ventricular drain. Out of these three, this is a pictorial representation. What is the placement of these ICP monitors we can have? As the name suggests, subarachnoid bolt. So subarachnoid bolt will be placed in the subarachnoid space. Epidural bolt will be placed in the epidural space, and EVD, external ventricular drain, will be into the lateral ventricles. Out of these three, the most important is the EVD, external ventricular device or external ventricular drain. It is a gold standard. It can be used to monitor as well as to drain the excessive CSF from the brain. And the position or the placement of the probe or the catheter is the Cocker's point. So this is how this is the way by which we can put and we can see the ICP. But there are some contraindications to the ICP monitoring. This is because patient might be on some anticoagulation therapy or might be suffering with coagulopathies. He might be having scalp infections or brain abscess. In these three conditions, it is totally contraindicated for the ICP monitoring. However, there are few complications are also which are related to ICP monitoring, and because of that, it becomes a limitation that in every setup we cannot perform the ICP monitoring. Like infections, these patients are always at the risk of infection. Infections such as meningitis, ventriculitis, wound infections. There are also chances intracranial hemorrhage because accidentally, if it ruptures any artery or the vein, it can also lead to the hemorrhage. It can lead to the device malfunction or difficulty with the placement. And sometimes because EVD is placed in the ventricles, it can lead to the ventricular collapse, which can result into a very major complication, tentorial herniation. What is herniation? We will be discussing in the coming slides. Now, the most important thing, the part what we are here, we all are present in this platform is the how to manage increased ICP. So according to current guidelines, we have got a tier system by which we can manage ICP very well. And it starts from 0 to 3. Like from basic measures, we can go to the higher implementations or higher interventions by which we can decrease the increased ICP. Under the standard measures, we all know we have to, where the certain nursing interventions can help to reduce the ICP. Then if it is not possible to reduce the ICP from the standard measures, we have to move to the higher interventions such as use of the mannitol, hypertonic solution, or we can use sedations, or we can maintain, or we can also have the extreme hypothermia for the patient. So this is how we have to raise the level of the management of the increased ICP. The one by one we will be discussing all these measures. The first is the ABC. Yesterday also we already discussed ABC in detail, and we can say that ABC is the most important thing to be managed in the TBI patients, because if it is airway, breathing and circulation are not intact in these patients, there will be always chances that the patient might suffer with hypotension, hypoxia, and these things will complicate the situations of the patient. So the may make it sure that the airway, breathing and circulation of all the patients you are attending with the traumatic brain injury must be patent. After maintaining the ABC, what the very definite measure we can see is the elevation of the head of the patient to 30 degree. It is most oftenly seen that the patients are usually lying in the supine position, which should not be there. Once the patient has been ruled out that the patient is not suffering with any spinal cord injury, make it sure that you are not supposed to elevate the head in the patients who are suffering with the spinal injury, because that may damage the tissues of the patient. But once it has been ruled out by the CT or the MRI that the patient is not suffering with cervical spine injury, the head of the patient has to be elevated to 30 degree. And what is the concept behind it? The concept is it will allow the venous outflow. It will help in the flow of the cerebrospinal fluid from the brain to the spinal spaces. So that means the CSF will not accumulate in the brain, and the ICP will start decreasing. It will also help and make it sure that you do not suddenly change the position of the patient. Certain jerky movement or sudden change in the position can definitely increase the ICP. So make it sure whenever you are changing the position of the patient, you should take the help of some another person, and then you can move the patient. And ties of ETT, mostly the patients who are suffering with moderate or severe traumatic brain injury usually are intubated. So we have to put the ties over the neck. Make it sure that because we have carotid artery on the neck, it should not be blocked, because if it is blocked, again the venous flow will be hampered. So make it sure that the cervical collar and the ties of the ETT are patent. They are loose enough to make the flow intact. The next is the manage the agitation and temperature. Why agitation is important to maintain? Because agitation will increase the body activity, especially the muscular activity. And it is not the muscular activity of the body, but it will somewhere will also increase the metabolism of the brain. Once the metabolism of brain tissues will increase, it will definitely increase the level of the ICP, because any small minute change in the activity of the patient will increase the ICP. So make it sure the patient is relaxed. Probably we often select sedation among these patients, so that the patient should not have increased cerebral metabolism rate. Plus, whenever you are performing the suctioning, make it sure that you do not perform suctioning more than 10 seconds, because one time you are putting the catheter inside the trachea, more than 10 seconds, again it will reduce the high oxygen level in the body, and it will increase the ICP. And temperature control, again maybe you have seen that the patients who are suffering with head injury patient are always on paracetamol or any analgesic. The reason being that we should not allow the temperature to rise, because 1 degree rise in temperature will increase 7% by metabolism rate by 7%. So take all the measures. You can use the tapet sponging, you can use the antipyretics, you can have the fans, you can have air conditioner according to the weather of your area. So according to your that, you have make it sure the temperature should not rise. Another, once these measures are not sufficient to maintain the ICP, we can move to the tier 1. So after tier 0, when we have maintained all the basic measures, we can move to the tier 1. In the tier 1, now we can move to the other measures. The other measures are the use of the hypertonic saline or use of the mannitol, because these are the osmotic diuretics. It will allow the flushing of the fluid from the brain, and hence ICP will decrease. But make it sure that it should not be corrected promptly, because it might cause other complications. So it should be given under advice by the attending physician, and so that the electrolyte levels are also maintained. And if hyponatremia is there, you can give the hypertonic saline. Then is the EVD. We already discussed that EVD is the gold standard for monitoring, as well as for the diagnostic, as well as for the therapeutic purposes of the increased ICP. So for that, CSF can be drained at the rate of 5 to 10 ml at one time. Then hyperventilation. We have already talked about that how oxygen is important in the body. So if we give proper oxygenation to the patient, the level of the CO2, that is the carbon dioxide, will decrease. Once the carbon dioxide will decrease in the brain, it will cause the vasoconstriction, and hence the blood flow to the brain will decrease, and it will help in the decreasing of the ICP. And make it sure that you maintain the partial pressure of CO2 between the 30 to 35 mm of Hg. And it should be for a very brief time. Don't over ventilate the patient. The reason for not hyperventilating the patient is because it might cause cerebral ischemia, because on the long run, if you're continuously giving the more and more oxygen and CO2 is less, so CO2 is causing the vasoconstriction. So if it will cause a permanent vasoconstriction, the oxygen supply to the part will not be supplied, and hence it will result into the cerebral ischemia. So make it sure that hyperventilation can be used, but for a very brief period. And the last measure of the tier 1 is the surgical management. If all the measures, like we have tried everything, still the ICP is not maintained, we can directly go for the surgical management. And if surgery, sometimes patient is not eligible for the surgery, then we can go for the tier 2. Now for tier 2, we have to use the strategies in combination. Strategies in combination means now we use the theory tier 0, tier 1 plus tier 2. In tier 2, we have to use the sedation. Sedation can be used because we have to manage the agitation among the patient. It will help in reduction of the cerebral metabolic rate of the oxygen, and make it sure that it does not cause the cardiovascular depression, and which can be easily maintained by giving proper fluid therapy to the patient. Yesterday also we discussed that circulation is very important. So maintaining proper fluid volume in the patient can help in maintaining the CPP, that is the cerebral perfusion pressure. Again, if modalities are not sufficient, go for the surgical management. And if surgical management is not possible, go for the tier 3. Now, tier 3 is the most aggressive mode by which we have to manage the ICP. ICH rather, intracranial hypertension. So as it is associated with the greatest risk of the adverse effect, still if we have to give the pentobarbital coma, then it is given as a bolus in the dose of the 10 mg per kg over 30 minutes for up to 2 hours, followed by, that is a maintenance dose for up to 5 mg per kg per hour, which can be given over a period of 3 hours. It can be maintained at the rate of 1 to 4 mg. Whenever we are giving a maintenance dose, it is always a lower dose, because now body has able to maintain a serum therapeutic level. Serum therapeutic level means a dose which is equally effective in the body. So now all the body cells will be acclimatized with the dose, and it has to be continued for 24 to 96 hours, and then it can be slowly tapered off. There are certain side effects of this therapy, such as respiratory depression, hemodynamic instability, immune system suppression, and paralytic ileus. Other agents which can be used are the thiopentone and the propofol. Another therapy which we can use in the tier 3 are the hypothermia. We always consider to keep the temperature within the normal levels for the time, because we in the previous slides also we studied that temperature is very important. Maintaining the temperature by tepid sponging or by giving the antipyretics is very important, because higher the temperature, more with the metabolic rate, more will be the ICP. So if these measures are not sufficient to control the ICH, that is the intracranial hypertension, we can also perform the hypothermia, that is suddenly lowering the body temperature of the patient, because it will suddenly reduce the cerebral metabolic activity, and it will decrease the ICP, and we can maintain the temperature from 30 to 34 degrees Celsius. It is induced by putting the normal saline through IV. So very cold normal saline can be given, but it is always to be given under supervision. Make it sure that your ward in charge is informed that if you are doing this procedure. And adverse effects of this therapy are shivering, electrolyte imbalances, cardiac arrhythmias, and sepsis. And to prevent rebound severe intracranial hypertension, rewarming should be done slowly. So once you are sure that the ICP has been reduced and temperature need to be returned back, it has to be very slowly to be put back, that is at the rate of 0.2 to 0.5 degrees Celsius per hour. There are certain complications of the intracranial hypertension: brain damage, seizure, stroke, coma. Among all these complications, one of the very important, which can be or without increased intracranial hypertension, is brain herniation. So what is brain herniation? Brain herniation is an emergency situation. It's an emergency pathological condition which occurs when a part of brain tissue is forcefully pushed from one side to the another. We usually hear of the sometimes umbilical hernia. So when a herniation means whenever a part of the body has changed its original position and has moved to the another position. So that is a herniation, and it can equally occur in the brain. So then it becomes a life-threatening situation and needs prompt treatment. There are some very typical clinical manifestations of the brain herniation, such as dilated pupils, headache, drowsiness, high blood pressure, loss of reflexes, seizures, abnormal posturing, rigid body movements, abnormal positions of the body, cardiac arrest, loss of consciousness, or coma. Now the thing is how to manage. There are some immediate interventions, and there are certain general measures to maintain the brain herniation, because it is not that situation that we give some medicine or we give some immediate treatment and the patient will be okay. No, it is not possible in the brain herniation. We have to move very gradually, step by step, so that the condition of the patient can improve over a period of time. So the first thing is maintain the airway, breathing, and circulation. We always emphasize on the airway, breathing, and circulation, because these are the primary management of the traumatic patients. So for that, because if these three things are intact, we can prevent many other secondary complications which can occur, because if because of lack of oxygen or because of lack of blood supply, so all the complications can be prevented if we maintain proper airway, breathing, and circulation. These patients need to have the intensive care, so it is better to get admitted into the ICU. We can provide the supportive measures, most importantly control of the increased ICP and treatment of the underlying disorder, because I already told you that the brain herniation can occur with or without the increased ICP. There are certain general measures, because as I said that brain herniation cannot be treated in one day. It has to be going over a period of time. So what are the other measures which we can take help so that the brain herniation remains in constant check? These are the mechanical ventilation to maintain the airway and breathing, and to be paralyzed so that the extra brain activity should be prevented. Sedation can be given to these patients. Hyperventilation for a brief period can be given so that the vasoconstriction can occur, and which can reduce the increased ICP. Proper fluids to be given. Make it sure that you neither over nor dehydrate the patient. Diuretics, especially the osmotic diuretics like mannitol, can be given to lower the ICP. Blood pressure control, again, a very important modality for these patients. In some, corticosteroids can be given, but make it sure that it is properly indicated for these, because it is not always indicated for patients, especially in traumatic brain injury. The role of steroids, it's not so common in the patients who are suffering with the traumatic brain injury. Then hypothermia, again, hypothermia, or I can say that normothermia. So make it sure that the temperature remains in the continuous check. Pentobarbital coma can be used for these patients. And if these brain herniation, if it becomes a chronic, if it is not controlled within the proper time, it can lead to some complications like brain death, and which we'll be discussing in the coming session, respiratory or cardiac arrest, permanent brain damage, coma, and ultimately death. To summarize my topic, I want to say that to maintain or to keep the intracranial pressure in check, position neck in neutral position and head of the bed elevated to 30 degree to facilitate the cerebral venous drainage. Normothermia is always important for these patients. You can take help of the tepid sponging, or you can take the help of antipyretic medications. Maintain the fluid balance. Normal saline, it is a most common solution which is used for these patients. Hyperventilate for a very brief period. Seizures, which can definitely increase the cerebral metabolic rate, has to be in check, and which can definitely complicate the elevated ICP. So it has to be given prevented by prophylactic therapy. Emergent surgical management should be considered when there is a sudden intracranial hypertension or refractory to medical management. When we know that our standard measures or our medical management is not controlling the ICP, we can take the help of the surgical management. And osmolar therapy, which includes the hypertonic saline and mannitol, can be used for severe and acute intracranial pressure. Early management of primary injury and prevention of secondary insults such as hypoxia, hypotension, seizures, infection play a paramount role in preventing herniation syndrome. So we as nurses, that's a take-home message, that we have to take a vital role in monitoring and make it sure that we are vigilant to detect any abnormal signs of increased ICP, because it can lead to the better outcome of our patients. Thank you.
Thank you so much, Madam Latika. I think many of the doubts about ICP management and brain herniation are clear by her presentation. Thank you so much. Now, I invite next speaker. She is going to emphasize the role of nutrition in TBI patients. So I would like to invite Dr. Manju Dandapani, Lecturer 9, PGIM, Chandigarh, to emphasize the role, to present the presentation on role of nutrition in TBI patients. Thank you.
Okay. Thank you, Renu. Am I audible?
Yes, ma'am. You are audible.
Yeah. So a very good morning to all. First of all, I would like to thank Latika for inviting me to deliver a talk on nutrition in head injury. So this topic is very close to my heart because now I know the importance of nutrition in traumatic brain injury. I'll just share an incident with you. When I was working as a nursing officer during my novice period, what happened once I was doing my night duty. So during the night, like at around 12 o'clock, I came to know that my severe TBI patient is having only intake of around 900 ml to 1000 ml. So the reason was maybe some technical issues during the morning and evening duty. So I informed the doctor, and then we tried to manage 1 liter fluid was given during the night, and by morning I could only maintain around 2 liter of fluid. But when I was handing over in the morning stuff went and complained to the DNS. So I got so much scolding that one is for not maintaining the fluid in intake, complete intake. and the other was for not taking a proper handing over during my night shift from the evening shift. Anyway, that made me to go and read about. So I initially thought that this is only what happened is little fluid deficiency in the patient, which is really required to overcome the increased ICP, which Ledika was just talking about, and to maintain the CPP, cerebral perfusion pressure and blood flow. So that was my understanding when I did that mistake. But then, however, I went and read much about more about it, and then it was really shocking to me when I came to know the nutritional changes or the metabolic changes that happens in the brain injury patients. That demands a very important role for the nutritional aspects of management. So today I will be sharing some of the, and when I did my MSc, that was the thesis also which I took, and really an explorative physiological analysis of nutritional markers we have done during that time. So, and which helped in even developing some of the nutritional guidelines and a part of traumatic brain trauma foundation nutritional guidelines. So I would share my screen. Is it visible?
Yes, ma'am, it's visible.
Yeah.
Yes, ma'am. And we can go for slideshow. Yes, ma'am.
Yeah. Now it's slideshow.
Yes, ma'am, it's slideshow.
So today we will discuss about the introduction, what is the importance of nutritional aspect of management in traumatic brain injury, and what are the nutritional indicators and nutritional requirements, and what does the current guideline says for the nutritional management, some of the nursing implications. So when we talk about nutrition in traumatic brain injury, why it's important? Because after once the patient is developing, undergoing this traumatic brain injury, there is a very severe hypermetabolic response that is taking place due to inflammatory reaction. The response is too high that lot of protein catabolism starts taking place, lot of changes that is taking place, so which increases the energy requirement of our body. And we know that from where do we get energy? We do get energy from glucose, fat and proteins that we consume, and brain is solely dependent on only on glucose. So you know that the brain it has undergone a trauma, the energy requirement, the requirement due to recovery process and everything is too high. And so it is very, very important for us to adequately or more than adequately, we need to supply nutrition to these patients. The other reason is they have altered GI tract. We all eat food through mouth, chew it. Saliva has a role in digestion, which starts in mouth and then it goes through esophagus. And but when we talk about severe traumatic brain injury patients, most of the time we are giving them feed directly into the stomach or to the jejunum. So you know that there is, and also this patient's GI tract is at risk of developing stress ulcer due to the stress related to trauma. So, and there can be minute bleeding vessels, bleeding which is taking place in the GI tracts, which reduces the absorption of diet that we provide to the patient. So the GI tract is altered, the feeding pattern is altered. The way we consume food is morning we eat a breakfast, lunch and dinner, maybe in between snacks, and you know what type of food you eat. And you know that the patients of traumatic brain injury may not be able to continue this feeding pattern which we generally follow. They will be depending on liquid diet, oral diet, semi-solid diet. They may be difficulty in eating some kinds of diet, tracheostomy, constipation, so many complications which change their feeding pattern. And then increased nutritional demand. Now I told that their energy requirement is high, and their the healing, the body need to heal, the brain need to heal, and they may be having polytrauma associated injuries. All this need to heal for that. And you know that every cell in our body is made of protein and lipids. So the nutrition is very, very important in high amount. So these all factors result in nutritional depletion and related complications. So when I was talking about, we did a study, and I can show you some of the findings that we have here. You can see that this is the albumin level of the head injury patients within 24 hours. You can see that this is low as compared to the normal. You can see that as the GCS was coming down, total GCS, the albumin depletion was high. And this is the only, this yellow color, that is the only 25% of the patients had normal albumin after within
Excuse me,
24
ma'am.
hours of. Yes.
Excuse me, Manju ma'am. Ma'am, please kindly raise your little volume because it's not
Yeah,
audible, ma'am.
Yeah,
Yes.
yeah. So
Thank you so much, ma'am.
approximately 25% of the patients. Can you tell them to send the annotation request once again? I just closed it. So 25% of the patients had normal albumin. All other 75% of the patients had hypoalbuminemia. That happened just because of the head injury, most probable, because there are many studies which states about the protein and like even albumin depletion. The initial period there were less studies, but studies are coming up now. So you can also see here that the mortality and unfavorable outcome in patients who had low albumin, low urine creatinine was very high. So it is very important for us to maintain normal protein level. This again shows that as the weeks increase, as the days of injury increase, they had high number of clinical signs of malnutrition. What are these common clinical sign of malnutrition in this patient? You must have seen. I know that majority of you are working in neurosurgery ward and trauma wards. So majority of these patients having peripheral edema on extremities, and their hands are swollen if you have noticed. Why it is happening? It's not dependent edema alone. It is mainly because of the hypoalbuminemia, the edema is developing. So the patients who had, the poor nutrition had more number of clinical features, and patients who had more number of clinical features had high mortality and poor outcome. You can see that these are the various parameters declined over the time, first week to third week. After the head injury, you can see this is mid-arm muscle circumference, this is tricep skin fold, this is the albumin, and this is the creatinine level. All were depleting, though we were giving them feed. It's not that we are not giving them feed, because though we are giving them feed, they were depleting, and you know that it is their demand is very high. So this is another study which is showing that the patients who had high nutritional depletion, or patients who were fed late, that means sometime we forget to start the feed in time, or some of the other reasons we are not able to start intubation, extubation, this complication, reoperation, all these things delay the feeding. So when we delay the feed, they have more incidence of pressure ulcer, and again, patients who have pressure ulcer have high mortality and poor outcome. So with all these facts, we know that nutrition is very, very important. And when we talk about some of the nutritional indicators, the first one is commonly in all of us, we do weight as an anthropometric measurement. But we know that when the patient is on bed, though there are measures to check the weight of the patients who are bedridden, but it is not available many places. The checking weight becomes very difficult. So we can check other anthropometric measurements such as mid-arm circumference, mid-arm muscle circumference, tricep skin fold thickness, etc. Again, to check the body mass index. To check the body mass index, we need weight and height. So now how to check the height of the patient whom you cannot make them to stand, and how to check the weight of the patient. So there are formulas to calculate the weight of the patient based on their knee length. Knee length, we can approximately calculate their weight, height, and from the height, we can calculate their weight. This will be approximate, not exactly. Still, we can calculate their body mass index, and we can know where do they stand, and we can calculate their caloric requirement, because we know that all these things are depending on the weight of the patient. Always the caloric requirement and other needs of the patients are based on weight of the patient. So we can use these anthropometric measurements, and subjective nutritional assessments such as medical history, poor dietary intake, symptoms of the patient, physical examination, etc. And blood values such as serum albumin, transferrin, lymphocytes, and even hemoglobin and other values will help. So based on body mass index, WHO has classified malnutrition into different category, and the cutoff is 18.5. More than 18.5 is normal, mild malnutrition, moderate, and severe malnutrition. So these are the parameters. You can look into the website and remember. So anything that is less than 18.5 is malnutrition. So we need to maintain a normal body mass index. So why nutritional requirement is very important, we have seen since still. So we have seen that severe head injury patients may have energy requirements as high as 120 to 250% above their basal energy expenditure. When I say that as high as 120% to 250%, so it is equivalent to when we are eating one chapati, they need to eat 2.5 chapati. Is this possible for a traumatic brain injury patient? Maybe having a tracheostomy, maybe a bit drowsy, maybe having swallowing difficulty, maybe on gastric feed. Is it possible for us to ensure this 2.5 times extra? Okay, however, when the patient is on sedation and paralyzing agents during the initial period to control ICP and maybe seizures, that time the demand may be little less because their energy expenditure is very low because they are totally chemically paralyzed. So that time it can be then 1.4, more than at least 1.4 to 1.5 times, 1.5 times more than that we consume in any form. They cannot eat chapatis and other things, but in any form, depending on the patients. But is it possible? We feel like, even recently I went across a study when I was doing a study, every time we see that nutritional inadequacy in these patients. Even we are not able to meet the regular, even if they did not have a traumatic brain injury, the caloric requirement that they need also we are not able to meet due to various reasons. I don't have to explain that to all of you because you all are working. Do you know how these patients feeding is interrupted due to various reasons? So their current guidelines include a caloric requirement of 30 to 35 kilocalorie per kg body weight and protein 1.25 to 2.5 gram per kg body weight. This requirement should be routinely reassessed and appropriately adjusted based on the observed nitrogen balance. So role of calorie, total daily calorie expenditure is calculated based on height, weight, gender and age. A rough estimate of basal energy expenditure for most patients is approximately 22 to 24 kilocalorie per kg per day. This is for any patient, but in TBI, we consider it as 25 to 30 kilocalorie per kg per day. So these are generally recommended. So what is the role of protein? We told that up to 2.5 gram of protein per day is to be given. So there is no point of giving so much extra protein because however our body can maximum do metabolize up to 2.5 only. So there is no point of just enriching the patient with protein, but we have to make sure that the daily need is met. Increased protein intake is beneficial when energy intake is less than energy expenditure. I told you that their energy expenditure is very high. Most of TBI patients tolerate standard protein formulas, whatever is available, kitchen feed or protein commercial preparations. Protein should be adjusted during the course of the treatment and may cause, if patient is having renal failure or acute kidney injury, we have to be vigilant while administering protein to those patients. What is the role of fat? We know about various polyunsaturated fatty acids, omega-3 fatty acids such as DHA, etc. are very important in for the brain healing, and it is a part of the brain. And requirement of fat 10% of total calorie and monounsaturated fat 20% of total calorie is required. And what is the role of magnesium? Magnesiums are membrane stabilizing agents. It stabilizes the excited brain membrane, like a neuron membrane of the neurons. It has role in cardiac as well. But when we give extraneous magnesium, there is a limitation of it to cross the blood-brain barrier. So we don't never give it as in a form of drug or anything until and unless patient develops some seizures and all. So as a routine practice, the clinical trials have shown that magnesium, but dietary supplementation is very, very important, though it is not effective as a medicine. Then role of iron, adequate iron intake improves brain function, reduces mortality in critically ill patient. It helps in maintaining the hemoglobin, which is again very, very important, and but depleted in patients of TBA. And it is found in spinach, whole white bread, ragi, rice flakes, and sunflower seeds. So we need to appropriately make the consistency of these food items before giving the patients, depending on the method by which they are consuming the food. So role of zinc supplementation for up to 1 month appears to improve protein metabolism and neurological prognosis, GCS, and overall recovery, cognitive stability, and memory of these patients. So for it is so zinc supplementation is added along with the normal feed. It is found in wheat, germ, bran, cereals, bread, meat, liver, and sea products, etc. And copper also is very important in maintaining the immunity, because these patients become at high risk of developing infection due to various trauma. It is found in nuts, seeds, wall bread, and dark chocolate. And selenium, it's having antioxidant properties. It is having role in synthesis of hormones and protects cell membrane from damage. Found in seafood, liver, egg, grain, seeds, etc. Role of vitamin B1, metabolism. It's a cofactor for the metabolism of glucose. It is found in grain products, legumes, nuts, and seeds, and organ meats. And B12 protects nerve cells by maintaining the myelin sheath. It's found in dark green leafy vegetables, milk, meat, fish, etc. And role of folic acid may enhance early functional recovery following TBA. In studies show that there is even depletion of folic acid in patients of TBA, which we had not studied. However, it is found in liver, yeast, asparagus, and beans, peas, broccoli, and nuts, etc. And role of vitamin A provides protection against infection. It is also found in carrot, yellow squash, spinach, etc. And vitamin E supplies oxygen to brain and slow down aging process. And it is having antioxidant property and neuroprotection effect. And it is found in plant oils and green leafy vegetables. Vitamin B6, it helps with metabolism of carbohydrates and fats, supports nervous system, found in all wheat product, fruits, and vegetables. Vitamin D maintains level of calcium and phosphorus in blood and increase absorption of calcium. It's found in fish oil, red meat, liver, egg yolks, and fortified foods. And omega-3 fatty acid, it is highly concentrated in the brain, and it's found in nuts, fish oil, oil seeds, salmon, flax seeds, chia seeds, etc. Requirement is 500 mg per day, combined EPA and DHA together. They are two types of omega-3 fatty acids. And role of fiber is very, very important. It helps in increasing the sugar from blood slowly. So it is a part of it enhances the metabolism. It found in whole grain bread, vegetables, fruit, pasta, beans, blueberries, broccoli, avocado, pomegranate, etc. It acts as antioxidants, boost memory, and prevent Alzheimer's disease in these patients. The patients who had TBA are also at high risk of developing Alzheimer's. And if it is there, it happens in a little elderly age, not youngsters. Requirement is 25 to 30 gram per day. And that fiber also intake is also very important in overcoming the challenges such as patient face due to constipation. Because of the immobility, majority of these patients may be having constipation. So fiber intake is very, very important. And so these were about various nutritional components. So we saw the importance of protein, fat, carbohydrate, and various vitamins and minerals. We have seen what is the importance, and we need to supply, and some of them in excess than normal requirement. So we know that the normal routine food that we consume, it is difficult for us to replace the same for the patient. So we need to identify the adequate nutrients and adequate food types which can be fed to the patient according to their feeding method. Some may be on, Riles tube feed to gastric or jejunum. Both can be given the same type of feed. Some may be drowsy, but they are consuming orally. Some may be having a tracheostomy, but consuming orally. So we need to look at the type, and some may be having a little, if the patient is drowsy, we may have to give them semi-solid instead of, like very drowsy patient, you should not be feeding only. Occasional drowsy, like slightly drowsy patient, you can encourage them to eat if they're having good cough and swallowing reflex. Okay. So what are the current guidelines? Mainly the guidelines are being developed by the Brain Trauma Foundation. So we have seen that head injury increases body metabolic responses and therefore needs early nutrition demands. Early nutrition demands, which is very, very important. So as nurses, this this early word is very important. Okay. Like I have, when I was working in as a staff nurse, or even now also sometime I have observed that among our busy schedule, we many times forget that, okay, patient, when the patient comes, we start them with IV fluid. Then we forget to start them with Ryle's tube feed. Okay, even though Ryle's tube feed to be started, sometimes the insertion of the Ryle's tube gets delayed. And then the fluid, the initiation of the feed gets delayed. Okay, so suppose today we have, we have even started or Ryle's tube feed. Sometime what happens, that same 500 ml we continue for 2-3 days and we forget to increase that. As nurses, we also forget to ask to the surgeons or the physician who is taking care of the patient to increase the sometime it happens many times, na? And many times patient may have to undergo a surgery, an extubation, a re-intubation, re-exploration, some investigation where NPO is required. So due to many reasons, these patients have various challenges in maintaining the total enteral feed. So early nutritional support reduces secretion of catabolic hormone, which are already increased in the setting. I told you that the catabolic hormones will be high and there will be a lot of breakdown of protein and other things, but early nutritional support reduces that. So it will, if you supply early, it is not only a replacement, it also reduces the catabolism which is initiated in the body. Okay. So there are various feeding methods. The common feeding method for the the severe TBI patients, like it is, others can eat orally, gastric feed, jejunal feed, and rarely parenteral feed, parenteral nutrition. These are the 3 ways of feeding. Better nitrogen retention is associated with jejunal and parenteral feeding. But after gastric emptying, altered gastric emptying, residual lower esophageal dysfunction, and aspiration pneumonia, all these complications are expected and in these patients, and this all complicate the gastric feeding. You know that when the Ryle's tube is seen, especially orogastric is there, the nasogastric is, the lower esophageal sphincter may be partially open, that can increase the risk of aspiration and enhances the micro aspiration, which already happens in this patient and can result in pneumonia and its associated further complications. And so early feeding. So when to start the feeding? Once the patient is stabilized, hemodynamically stabilized, and the vitals are stabilized, we need to immediately think of starting the enteral nutrition. So it also ideally to be considered something similar to a vital. And starting as early as within 24 hours would be best. If 24 hours to 48 hours, that is better. And enteral route is preferred due to reduced risk of hyperglycemia, infection, and cost effectiveness. However, you know that we cannot, we have to give the near normal feeding pattern to this patient. We know when we talk about the enteral feeding, it is more physiological as compared to parenteral. Parenteral is we giving through central venous line directly into the blood nutrients. But in enteral feeding, we are giving to GI tract and then it is getting absorbed from there. You know that that is normal, more physiological as compared to parenteral. And so every time we stand more close to the normal physiology, the outcome will be better. And but parenteral nutrition may have complications such as hyperglycemia, infection, and high cost. So, and another point, so early feeding within 24 hours is best, I told, and attainment of total enteral nutrition. Total enteral nutrition means we stop the IV fluid and we put the patient fully on enteral feed. Okay. So every word is important. Attain, total. Total means complete caloric replacement. Enteral, that is through GI tract, if it is orally best, otherwise orogastric or jejunal. Nutrition as early is very, very important. So this is a finding which shows that the patients who had attained early, total enteral feeding within 3 days had less depletion in the mid-arm muscle circumference, which is an important nutritional indicator as compared to patients who had who were fed completely after 7 days. And also you can see that they had independent impact on the mortality of the, unfavorable outcome of the patients. So the Brain Trauma Foundation also recommends that total nutrition support should be achieved within 7 days of the injury. I told you that initial period there would be some challenges. Gradually we increase. Patient also take some time to adapt to the new feeding pattern. So at least within 7 days you need to some or the other way you need to attain the complete feeding. But if it is within 72 hours, it would be better. Then installing enteral access and starting enteral nutrition should be attempted as soon as volume resuscitation and is completed and patient is hemodynamically stable. And this is one of our study, which is a part of the Brain Trauma Foundation guidelines. And now role of parenteral nutrition. Role of parenteral nutrition is preferred when sufficient oral and enteral feeding is not possible for these patients. When patient is having vomiting, we are not able to attain, the malnutrition is severe, then only we go for parenteral nutrition. Total intake may be approximately 2000 to 3000 kilocalorie per day, including 35 to 130 gram amino acids per day. And primary advantage is only well tolerated. There is no vomiting, diarrhea associated with this, but the patient can have other complications and side effects. It is preferred if higher nitrogen intake is desired or if there is increased gastric emptying or uncontrolled diarrhea due to antibiotic use and feed intolerance. Cerebral edema is potential contraindication in parenteral nutrition. And current guidelines also says that equal attention should be paid to overfeeding. We should avoid overfeeding because that also can result in some side effects such as complications such as hyperglycemia, obesity, refeeding syndrome, fluid electrolyte abnormality, etc. So we know that like from many studies, we know that these patients are having nutritional deficits and requirement. So let us also with this look at some of the nursing implications. So enteral nutrition should be started within 24 to 48 hours of admission as soon as possible. Patient is stabilized. Complete and isotonic formulas should be initially chosen so that the patient will tolerate this and then gradually go to the normal pattern. And symptoms such as nausea, vomiting, abdominal distension, intestinal sounds, flatus and fecus elimination should be assessed to monitor the gastric intolerance. Gastric residue is measured every 4 hours during the gastric feeding. And if it is like we usually say less than 150 ml only, we should feed the patient. But in this patient, as such, GI system is not much affected. We don't have to give so much importance to a slightly even more than 150, even up to 500 ml, we can feed the patient. We can give stress ulcer prophylaxis to prevent stress ulcer, and we can give IV metoclopramide if the patients are having vomiting, nausea, etc., and a gastric intolerance. And always remember to elevate the head end 45 to 90 degree, or when like you always remember the caregivers also sometimes if they are feeding while training, the head end elevation is very, very important. Otherwise, there is very high risk of aspiration. So, but I have many times seen that like these kinds of small mistakes are happening. These all are negligence. The patient is developing an aspiration due to that. It is a nursing negligence. Maintain blood glucose between 110 to 150 mg per deciliter during nutrition support because more strict control could lead to harmful hypoglycemia. So the stress ulcer management is also one of the important aspects when we talk about the nutrition. So we may give proton pump inhibitors or antacids as the time goes. Initial period H2 Rantac or pantoprazole we give. Later we may change to occasional antacids or other things. And elimination management is very, very important. Diarrhea, management of diarrhea, constipation prevention of these things are very important to facilitate the GI feeding, because you know that it has a direct role on
sorry, ma'am,
nutrition.
we have a
So to
short
summarize,
time.
this is a summarizing slide. So we have seen that some of the anthropometric measurements such as weight, height if possible, otherwise mid-arm circumference, triceps, fold skin thickness, and biochemical parameters such as HB, albumin, urine creatinine, these all are important. And 15% of the protein calorie should be part of the total calorie. And supplements such as glutamine, zinc, etc. can be given. Early feeding is very, very important. When we talk about feeding time, initiate within 24 hours and complete attainment of nutrition within 72 hours, even at least 7 days. Feeding method, jejunal feed or orogastric or nasogastric as compared to total parenteral. And then we need to gradually bring to the normal physiological pattern of feeding. And even there is continuous versus bolus versus intermediate. So continuous is not recommended because it doesn't match with normal physiology. Maybe in the initial period, we can go for continuous, where we give feed like IV fluid. So for the better tolerance, but gradually we bring back the patient to the bolus, which is more physiological, okay? And if only severe intolerance, we have to go ahead with total parenteral nutrition. So a healthy diet is an important key to maximize brain's potential after a brain injury. So nurses have very important role in maintaining the nutritional aspect of the management of traumatic brain injury. And this nutritional aspect of management is very important. You should not be ignoring. So anytime you find any deficit, you need to really coordinate with the neurosurgeon and the dietitian and ensure that the patient is getting adequate calorie of that day, which is very important for maintaining their healing and recovery and everything. So every shift you need to check at the end of the shift. When the beginning of the shift, you need to check whether the patient is going to get how much. If the the doctor is writing 200 ml feed or 300 ml feed every 4 hourly, then you need to calculate and see this is going to meet the entire day's requirement or not. If not, you need to approach and get it corrected. And at the end of every shift, beginning of every shift, it is very important for you to have an eye on this nutritional aspect and nutritional intake and other things. Thank you so much. Thank you, Lydia.
Thank you, Dr. Manju Dandapani, for explaining us the role of nutrition in traumatic brain injury patients. Before going to the next speaker, I would like to request all participants kindly put their questions or comments in the description box. Okay, for the next lecture, I would like to call Dr. Raghav Singla. He's Assistant Professor, Department of Neurosurgery, PGME at Chandigarh. Sir is going to discuss about the management of the complications related to traumatic brain injury. Over to you, sir.
Hi, Latika. Thank you so much for having me, and thank you to the entire team for this wonderful and giving me the program. I'll presentation just if the slides are visible. Can you
So
see the slide?
No, sir, it is not visible. So visible now.
Okay, thank you. I'll just start. Yes, so I will be discussing about management of conflict.
So kindly make the
Yeah,
presentation in the slideshow.
Hello?
Yes, sir.
Yeah. So I will be speaking on complications related to TBI and their management.
You can off the video from your side if some internet connectivity is the problem, or from your side. Otherwise, if it is going well, then you can continue, sir.
Okay, I think that's okay for me.
Okay, thank you, sir.
Yeah, so I will be talking about complications related to TBI and their management. So when we talk about traumatic brain injury, complications can be in the early phase, the middle phase, and then the later on, when the patient presents at follow-up. For the most part, I will be discussing the complications that we see in the initial period when the patient is admitted in the hospital rather than during the long-term recovery phase. And I'll focus my talk on the basics, but still the most important things that affect the management of these patients: hyperthermia, sugar control, seizures, pressure ulcers, and hypoxia. So we have seen that a lot of patients in the post-op or post-injury period, when they are in the ICU or the ward, they would have fever, and this is very commonly seen in traumatic brain injury patients. And the thing with fever is that any rise in body temperature, especially high degree rise more than 40 degrees, is associated with long-term permanent neurological deficits. So when we see these patients, that there is a post-op patient who is M6, who's in a drowsy status, and then they start developing some hospital-acquired infection, they develop a fever, and we see that their, sensorium dips, they have problems in their memory, in comprehension and problem solving. And as a result of these, a long-term morbidity and mortality of these patients is significantly worsened. And that is why it is very important that we aggressively control hyperthermia in these patients. As part of nursing care, we recommend that there is a frequent measurement of the body temperature. This should be done on a 4 or 6 hourly basis. In some patients, this may be required even more frequent than that. And any of the body temperature, whether it is too cold or it is too low, this must be reported. So what are the methods that we normally use for managing of hyperthermia? The first step would be bedside techniques such as cooling blankets, using ice packs. We may use a fan. We may ask the relatives and the staff do some tepid sponging of the neck, axilla, and groin. This helps to bring down the body temperature. And then we can resort to pharmaceutical methods using paracetamol and IV drugs. In patients with hypothermia, we avoid aggressive we to tackle the hypothermia because, as I've said, that leads to long-term morbidity. We try to maintain temperature. When they come within the first 48 hours of injury, we do not warm them actively too much. If they are cold on arrival, we just try and maintain their normal body temperature. And if they are hypothermic, we try and cool them towards normothermia. Again, one of the most important complications in post-op period is seizures that we see the patients may be having. So these are again divided by the timeline: immediate seizures which occur within 24 hours, early seizures which happen within 1 week, and late onset seizures which happen after 1 week after injury. So the important part about seizures is that in traumatic brain injury, especially patients may be comatose, they may not have this full-blown seizures that we classically describe, that they have an aura, then they have all these symptoms, they are tonic-clonic movements, or they have a full-blown GTCS. They may be just subtle changes in their heart rate, in some rapid eye movements of the eyes, and there may be some frequent blinking, chewing movements. So all of these things should alert us that maybe they are about to have a seizure or they are having a seizure. For patients who are conscious, we may see some alteration of their consciousness. We may see the GCS has dipped, they have become unresponsive. Some stereotypical behavior, like I mentioned, that there may be some chewing movements that are persistent. There's some lip smacking or grunting movements, or they may be having a full-blown GTCS episodes, which is characterized by tonic-clonic posturing of the arms, followed by some clonic movements. Following the seizure episode, we see that these patients have a prolonged postictal period in which they are difficult to arouse, and they may be more drowsy than their pre-ictal period. This may last for a few minutes or maybe much longer in some of these patients. For patients who were conscious prior to these seizures, we may see that they are significantly confused in the postictal period, and they may report headaches, dizziness, or they are drowsy and want to sleep a lot. So what do we do as part of nursing care in these patients? So one of the first thing is to assess that whether a patient is having a seizure or not. And early detection of seizure can also help us in giving early control of the seizure. The first thing that we need to do is maintain their airway during this time, maintain their oxygenation, and make sure that they do not aspirate in case they are about to vomit. We must prevent them from any injury. So we keep the bed position low, the side rails up, and we consider padding if we think that during these tonic-clonic movements they may be injuring themselves. So our aim during the seizure is to protect from any injury, we loosen any restraints, and we want to maintain their airway, breathing, and circulation. Once the seizure episode has abated, we reassess the patient, see their pulse and respiration has normalized. If they are unresponsive, we must keep the airway patent. We insert an oral airway if needed, and we may use suction to remove all the oral secretion or vomitus that may have collected during this time. Assess the vital signs. We should look at their pulse, respiration. If needed, we begin CPR, we start cardiac contractions, and we call for help and call the entire team. The next complication is the sugar levels that need to be managed. We need to see whether they are hypoglycemic or hyperglycemic. Hyperglycemia is the more frequently observed complaint in these patients and prolongs the brain injury in the long term. It causes worsening of the secondary brain insult. And we want to reduce the plasma glucose just to the normal level, because having it too low will also decrease the cerebral glucose and affect the brain energy crisis. So both need to be avoided, and we want to keep them in the range of normoglycemia. But even in the range, we tend to keep it towards the higher normal range. So we keep it around 120, 130s, and try and maintain it to the higher normal so that there is adequate sugar influx to the brain. So again, as part of nursing care, we maintain the sugar levels around 120, 130, 110 to 130 in that range. So keep it slightly normal and aggressively tackle any hypoglycemia that may be occurring, because hypoglycemia can be significantly fatal in these patients. Next up is hypoxia. So most of the time, the brain normally adjusts its own blood flow in response to its need. And post-traumatic brain injury, the brain has a higher metabolic demand and it needs more blood flow. So there is auto-regulation of the cerebral blood flow that is based on the levels of CO2. The normal CO2 level is around 35 to 40. However, in traumatic brain injuries, to decrease ICP, we sometimes maintain it to a slightly lower level between 30 to 35. If there is one reason, there is hyperventilation, so there may be a tube block or the patient may not be having adequate respiratory rate and he's unable to wash out the carbon dioxide. So there is an increase in carbon dioxide and this promotes vasodilation. And this also increases the intracranial pressure and decreases blood flow to the brain. Ventilation and watch for signs of a tube block, decreased respiratory rate, or for some reason that the patient has become drowsy and is not being ventilated properly. Also, we have to see the hypoxia, the oxygen saturation levels, because lower oxygen will worsen the secondary brain injury, and that will also lead to a worse outcome. As part of nursing care, we must see the ventilatory settings of the patients are adequate. The pulse oxygen saturation is more than 95% maintained at all times. And we see that the patient has a normal carbon dioxide concentration in the ABG around 35 millimeters of mercury. And report any very rise in carbon dioxide because that will lead to raised ICP also. In terms of post-op, when these patients are post-injury, there may be multiple injuries in the lungs also. So they may have some acute lung injury, there may be acute respiratory distress syndrome. So normally in the ventilatory settings, we tend to maintain them on a positive end expiratory pressure. By doing this, we are trying to prevent atelectasis and decrease the physiological dead space by doing an overdistension of the normally compliant lungs. As part of nursing, we maintain the oxygen saturation. As I said earlier, it should not go below 90. And whenever it is going towards 90, this is a sound for alarm. We take frequent ABG measurements as and when indicated. Whenever we are going to do suctioning, we pre-oxygenate the patient and we do not suction for more than 10 to 15 seconds maximum. And this also leads to a transient rise in ICP whenever we are suctioning and the patient is coughing. So if we are doing ICP monitoring, we need to understand that these rises are actually occurring during suctioning and not aggressively tackle them in terms of being a brain insult. We ensure that there are no bandages around that are causing ventilation or any compression around the neck. And we note that the neck is not hyperflexed or hyperextended and try to keep it in a neutral alignment. So this increases the venous drainage and also decreases the cerebral venous pressure. One of the most common things that we see in these patients of traumatic brain injury is pressure ulcers. So this happens when there is some localized injury to an underlying tissue and skin. And this is because of chronic compression against a bony prominence. And this happens especially in patients who are bedridden or who are unconscious and there is some chronic pressure. So this happens over all the bony prominences. There are various stages which can start just from edema of the skin and a non-blanchable redness to it going right up to the bone and making big wounds. So these are the common locations that we see them depending on the patient's nursing position. They may be seen in the occiput, the acromion process, shoulder, the sacrum, the buttocks, the heels, and also on the inner side of the knees when they exert pressure against each other. So these are the common locations that we must check for pressure sores. So the first defense against pressure sore is identification that a pressure sore is starting to begin. And we must note the risk factors in patients who may have a pressure sore and also detect them at the early stages. So there are two scales, important scales that can help us identify which are the high risk individuals, the Braden scale and the Norton pressure sore risk scale. And these are mostly dependent on their sensory impairment, how moist the skin is, whether the patient is able to walk or he's bedridden, what is the amount of mobility of the limbs, what is the nutritional status, and what is the amount of friction that is. So based on these scoring systems, we can assess that which are the patients which are more likely to develop bed sores. So a similar scoring system is the Norton pressure scoring system, which also grades under the physical condition, mental condition, activity, mobility, and continence of the patient. So these are scoring system which basically tell which are the patients that are at risk of developing a pressure sore. And what are the preventive measures that we can take against them? The number one is inspection. We need to inspect the skin regularly and we need to identify early. So we need to stop the bed sore at a grade 1 stage, or even before that. We keep seeing what are the areas which are at risk, which are having some chronic pressure, or which may be desensate, or which may not be mobile. And so we look for these areas where the bed sore may be developing. Then is bathing. We just clean all these areas with mild soap and warm water and use a no rinse cleaner and pat it dry after this thing. No aggressive rubbing on areas which are already red and may be predisposed to bed sores. If the skin is moist, we dry it with the talcum powder. If it is too dry, we just apply a moisturizing lotion above it. Free it from any irritant materials. Then we must prevent any urine exposure or any soiling of the skin. So for this, we may need catheterization of the patient. They may need assistant urination and frequent diaper changes. For patients who can be mobilized, we must encourage mobilization actively or passively on wheelchairs. We use pressure reducing devices on patients who are bed bound. We may use air mattresses, water mattresses, foam wedges between the knees to prevent any compression. Use a dynamic device, which are alternating pressure devices. So these all can help us in preventing pressure ulcers. Whenever possible, we should give them accessible and adequate support to the patients and caregivers, and train them in lifting, turning the patient, and mobilizing the patient, because in the long term, it is going to be the caregivers and the patient's relatives who are going to be actively managing these patients. In terms of their positioning in the bed, we must see a bed elevation should be no more than 30 degrees. They should be frequently repositioned and have a turning schedule. Every 2 hours, their position is changed. And whenever possible, they should be repositioned in bed under with uh, extreme care and not causing any friction damages. Prevent any bony areas from injury by proper positioning and cushioning, and they should never be dragged, because that friction can cause early onset of these ulcers. The most important defense against these bed sores is adequate nourishment. They should maintain a high protein, high calorie diet, and ma'am has talked a lot about it in the last lecture, and a very good presentation on the dietary requirements in these patients. And for bed sore prevention and also their healing, the adequate nutritional support is very essential. We must assess the number, location, and size of the sores. Look for any exudates, any signs of infection that may be forming, any scars they may be forming, any deep-seated infection or abscesses that are formed, and they must be handled aggressively. So for bed sores, the early management is the best management possible for these patients. So assess them frequently, see which are the patients at risk of these ulcers, move and change their position regularly, keep the skin dry, protect any bony areas. Nutrition is very important, and manage any ulcers that are happening with aggression and with the aseptic technique. And thank you from my side. Thank you.
Thank you so much, sir, for wonderful presentation on management of complications related to traumatic brain injury. For the next lecture, I would like to call upon Dr. Mona Lisa, lecturer, National Institute of Nursing Education, PGIMET, Chandigarh. Ma'am is going to highlight brain death. Ma'am, over to you. Ma'am, you are not audible. Ma'am, unmute yourself.
Thank you very much, Latika.
Thank you.
Thank you for inviting and giving me opportunity to share. I hope this is visible.
Yes, ma'am. Ma'am, slideshow. Kindly view your slides in the slideshow.
Yeah.
Thank you, ma'am.
So till now we were talking about how to deal with the patients, how to look for their nutrition, how to manage, particularly nursing management of the TBI patients. So I'll be talking about brain death. So time goes by and you never paid the cost. Without your mind, your body, it's lost. Should we help to keep you alive? Now's the time to help you die. With this, this is for the brain dead patient. So thanatology is the science dealing with the study of death, and most ancient civilizations accepted death as an easy, determined empirical fact, not requiring further elaboration. So if we talk about history, traditionally health has been defined as cessation of all body functions, including respiration, heartbeat. So since now it has become possible to revive some people after a period of cessation of respiration, heartbeat, or other visible signs of life. And it is also possible to maintain respiration and blood flow artificially using life support treatments. So there is a need, or a need is felt to have an alternate definition of death. So in recent decades, concept of brain death was emerged. The brain death criteria, or a definitive brain death criteria, a person can be legally pronounced dead. In India, brainstem death was legalized in 1994 when the Transplant of Human Organ Act was passed. Coming to definition, if we want to define brain death is defined as irreversible loss of functions of brain, including cortex as well as brainstem. Or we can say a patient is determined to be brain dead. He is legally and clinically dead. So before going to assess for a patient for brain death, we need to consider some factors. That a patient must have normal core body temperature, because hypothermia can make it difficult to perform brain death assessment. And we should give sufficient time to clear the effects of sedations or paralyzing drugs, because sometimes these patients are sedated and we give them drugs which depress central nervous system. Certain medical conditions such as hypertension, hypoglycemia, electrolyte imbalances, they also need to be corrected before assessing the patient for brain death. Now, moving on to the criteria of brain death. There are three determinants: irreversible coma, absence of brainstem reflexes, and apnea. When we say irreversible coma, these brain dead persons cannot be awakened by any stimulus, whether it is pain or by speech. And we know the score of 3 on GCS indicates profound unresponsiveness. Another determinant was absence of brainstem reflexes, which include absence of pupillary reflex, oculovestibular reflex, oculocephalic reflex, corneal grimacing, gag, and cuff reflex. Absent in pupils, what we see, there should not be any response to bright light bilaterally. And the size of pupil will vary from 4 mm to 9 mm. That is, they will be mid-positioned and will be dilated. But here we have to note that the presence of widely dilated pupil is not a necessary criterion for brain death, but fixed pupils with no response to light is a mandatory requirement for its diagnosis. In brain dead patients, no vestibular reflex will be there, oculovestibular reflex will be there. That is, there will be no deviation of eyes to irrigation in each ear if we irrigate it with 50 ml of cold water, or we do a caloric test. But here we have to ensure that containing membrane of the ears is intact, and we have to give sufficient time, that is 1 minute after injection, and we have to wait for 5 minutes while testing on other side. Then there will be no oculocephalic or doll's eyes reflex. Here the patient will appear to be looking at a particular point, and his eyes appear to be moving away from the direction in which the head is turned. If the eyes remain stationary, the reflex is absent. And this test must not be performed in patients with an unstable cervical spine. Now, other brainstem reflexes which would be absent in these candidates with brain death: no corneal or the jaw reflex will be there, no grimacing to deep pressure on nail, supraorbital ridge or temporomandibular joint, no response after stimulation of posterior pharynx, or we can say cuff reflex, or this gag reflex. No response to thoraco-bronchial suctioning, that is cuff reflexes will be there. Another determinant of brain death is, while doing clinical examination, is apnea test. There are certain prerequisites for this, that all other brainstem reflexes have been confirmed to be absent. Whatever we have studied in previous slides, We have seen that brain stem reflexes will be absent in patients with brain death. So besides that, the person should be normothermic. That is, the core body temperature should not be less than 36.5 degrees Celsius. Should be normotensive. Systolic blood pressure should not be less than 90 mm of Hg. Should be euvolemic, preferably a positive fluid balance in previous 6 hours. Eucapnic, that is, partial pressure of carbon dioxide should not be less than 40 mm of Hg. No carbon dioxide retention state in patients like COPD should be present. Now, how to do apnea test? How to check? We need to connect a pulse oximeter and disconnect the ventilator. Deliver 100% oxygen at the rate of 6 liter per minute into the trachea. Look closely for any respiratory movements, that is any abdominal or chest excursions. Measure arterial partial pressure for oxygen, partial pressure for carbon dioxide and pH after approximately 8 to 10 minutes, and reconnect the ventilator. So, if the respiratory movements are absent and arterial PCO2 is more than 60 mm of Hg or 20 mm Hg increase in PCO2 over baseline normal partial pressure of carbon dioxide, the apnea tests are marked as positive and patient is considered to be brain dead. If the respiratory movements, on the contrary, if the respiratory movements are observed, the apnea test results are marked as negative. Now, there are certain contraindications where we cannot do this apnea test. It is the phrenic nerve injury or phrenic nerve dysfunction, usually in high cervical cord injury patients. Now, besides this clinical examination, sometimes we need to go for ancillary tests. These are the confirmatory tests or which are optional and reserved for the situations when clinical diagnosis cannot be completed or it is doubtful. So indications are cranial nerves, when cranial nerves cannot be adequately examined due to severe injuries, neuromuscular paralysis is present, heavy sedation is given to the patient, apnea test is not valid or cannot be completed, when confounders render clinical examination unreliable. We cannot conclude any clinical examination, and we have very short duration of observation period for the patient. So these tests include cerebral angiography. This is a traditional gold standard for brain death, invasive and requires transportation to radiology department. And blood pressure must be monitored during this procedure, and severely damaged brain may have lost autoregulation, causing blood flow to vary with changes in perfusion pressure. So the cerebral angiography will indicate the same. Transcranial Doppler. Transcranial Doppler is a non-invasive technique and was found to be highly sensitive in determining absent cerebral perfusion. Then MRA, that is magnetic resonance angiography, that is will show absence of arterial flow on MRA, supports the diagnosis of brain death. This MRA will show variable degree of cerebral edema and mass effect as well. The other is sensory evoked potentials. In many studies of the patients with brain death, most patients have no response to test for somatosensory and brainstem auditory evoked potentials. So this test is therefore useful in only distinguishing isolated brainstem death from high cervical transverse cord lesions and focal bilateral lemniscal lesions. Other is EEG, that is electroencephalography. So loss of bioelectric brain activity for at least 30 minutes of recording as measured by 16 or 18 channel EEG is a reliable confirmatory test for diagnosis of brain death. But there are certain pitfalls of it. These will include if the patient is in ICU, there will be artifacts that may lead to spurious results. EEG may also not show electrical activity in barbiturate coma. Sometimes we induce them barbiturate coma among them, so this will not show any electrical activity. The EEG is significantly affected by hypothermia, drug administration, and metabolic disturbances. So the clinical utility of this test is diminished. Now, observation period. How much time we have to observe a brain dead patient? It is recommended that for 6 hours with up to 24 hours, a patient can be observed. But those patients who are resuscitated after cardiac arrest, observation could be up to 24 hours from the time of arrest. And because some spontaneous improvement in brainstem reflexes can occur within that period. And those who have been on induced hypothermia, their recovery time may be extended up to 3 days. Now, the consequences and considerations following brain death. Once brain death diagnosed, patient and the patient is declared that that is what in adults, single brain death examination is minimum standard for diagnosing brain death, and in children, as per recent guidelines, recommendation is for 2 separate brain death examinations as minimum standard. And we need to give organ support. We need to go for continuation of mechanical ventilation or medications to maintain BP. Should be continued, because in case the candidate is for organ donation or the patient is pregnant, to continue support for the fetus. Now, evaluation team, who should clinically evaluate for the brain death? In India, according to the Transplantation of Human Organs Act 1994, its subsection 6 of section 3, brainstem death refers to the stage at which all functions of brainstem have permanently and irreversibly ceased. And this thing has to be certified by board of medical experts, which consists of medical superintendent in charge of hospital in which brainstem death has occurred, a specialist, a neurologist or a neurosurgeon, which is nominated by MS from a panel approved by appropriate authority, and the doctor under whose care the brainstem death has occurred. One amendment in 2011 has been made, which allowed the selection of surgeon or the physician and an anesthetist if approved neurosurgeon and neurologist is available in the setting. Now, moving on to role of nurse while caring the brain dead patient. The role is multifolded. We have to monitor for signs of death. We have to see if the patient is moving towards brain death. We have to act as communicators. We have to communicate with the family for clearing their any confusions or any queries. And besides that, we have to maintain routine care of these patients. Like frequent turning, pressure ulcers, skin care, dressing changes, urinary IV catheter care to minimize the risk of reactions. And we have to regularly send lab investigations and check for their results. Besides that, we have to see some physiological changes. We have to maintain hemodynamic stability. We have to maintain endocrine abnormalities. We have to see that the body temperature is normal body temperature is maintained, maintenance of coagulation functions, maintenance of respiratory, cerebral, renal, electrolyte, and nutritional issues we have to see for these patients. This is to summarize what we do in case how to diagnose brain death. If we have a comatose patient who is on ventilation, and their irreversible damage of known etiology has occurred, and then we will look for any reversible causes of coma. If there is no reversible causes of coma is there and the patient is into irreversible coma, then we'll go for clinical examination. We'll see for any absence of brainstem reflexes. We'll see for motor responses in cranial nerve distribution. We'll do apnea test. If these all are positive, then we'll repeat clinical examination and confirm the findings, and we'll declare the patient as brain dead. To conclude, a number of serious ill patients are now being revived because we have very good ICU facilities available nowadays, and many of them still they recover, and a significant number end up being brain dead. It is imperative that the treating team fully understand the intricacies of the brain death, and so that they can discuss in detail with the family the implications of continuing treatment and its repercussions, and also the option of patient being an organ donor can be explored. So I would like to end my presentation. As we know that this concept of death, it's been part of this has been perceptions of death have been reflected in our poetry, literature, and pictorial art. So this is a Roman author who actually said, "So uncertain is the man's judgment that they cannot determine even death itself." Thank you.
Thank you, Dr. Mona Lisa, for giving us in detail the brain death. For the next lecture, I take this opportunity to invite Dr. Sukhpal Kaur. Ma'am is lecturer and academic in charge, National Institute of Nursing Education, PGMER, Chandigarh. Ma'am is talking about rehabilitation of traumatic brain injury patients. Over to you, ma'am.
Are my slides visible?
Not yet, ma'am.
Now visible?
No, ma'am.
I'm sharing. I'm sharing. The previous speaker has closed the presentation, or?
Yes, ma'am. The previous speaker has closed the presentation. Yes, ma'am, it's visible now.
Visible now?
Kindly make the slides in slideshow.
Yeah.
Yes, ma'am.
Fine. Thank you, Latika, for the kind introduction. I'm going to talk about rehabilitation of the patients, which is again very, very important aspect to bring the patient back to the normal life. So the content I'm going to cover is, I'll be just talking about what are the various neurological deficits these patients can develop, and then a bit about the definition, the principles, the goals and types of rehabilitation. What should be done in acute condition once the person is just hospitalized and maybe in comatose condition in the hospital. Then I'll be touching upon certain new advances in the rehabilitation, specifically for the motor power, to increase the motor power of the patients, including robotic training. There is one therapy, that is the constraint induced movement therapy, commonly known as CIMT. I'll be talking about body weight supported treadmill training, then transcutaneous neuromuscular electrical stimulation, non-invasive brain stimulation, mirror therapy, which has also been studied in our college, and then certain interventions for the communication, bowel and bladder incontinence, and I'll be ending up with the certain exercises to improve the dysphagia in these patients. We know that head injury can account for a great deal of chronic disability, and it is going to have a lot of disabling effects after the head injury. And I always say, whenever I see any person without helmet, I used to say that head injury ek baar hi hona hai. If it is a minor, it's okay, but if it is a moderate or severe head injury, it can have a lifelong impact on the individual. So throughout, the person might be dependent upon the family members and can increase the burden overall on the society and at large for the country. So brain injury is a life-altering event, physically, cognitively, emotional, psychosocial, and it is going to have a socioeconomic impact on the people. And many times we see that the head injury patients, they are majority of the time, they are in their most productive period of life, that is around 20 to 40 years of life. So we can just think of the impact this particular group is going to have on the parents and on the society once the person becomes bedridden for whole of their life. So it's very important that certain rehabilitation aspects are taken into consideration so that we are able to improve the quality of the life of the patients as far as possible. There are various types of deficits which these patients can have, including motor deficit, talking about the hemiparesis, hemiplegia, ataxia, dysphagia, aphasia, visual field deficit and sensory deficits. Talking about the cognitive changes, there could be changes in the memory. Usually, many times it has seen that person just become like a child. He usually forget about it, especially if the survivor is from the severe head injury. The person may not able to make any of the decisions regarding his life or even day-to-day life activities. There could be problem in the planning, in sequencing, in judgment, processing speed, organization of the things, even self-perception, problem solving, and even thinking. There are a number of behavioral changes, including because the person is incapacitated to do the things. There could be depression, there could be mood swings, disinhibition, lack of response to social cues, problems with emotional control, difficulty relating to others, reduced self-esteem, and later on leading to stress, anxiety, and frustration. So all these neurobehavioral sequelae produce the greatest disruption in quality of life of the patients. So it's very important, it's a need of the hour to have more effective and patient-tailored rehabilitative approaches to maximize the functional outcome of the neurological injuries as well as patients' quality of life. So let us see what is the rehabilitation. I'm sure everyone of us is aware of that. It has been taken from the Latin word with habilitans, which means to make again or to be able again. So it is the process of helping a person achieve the higher level of function, independence, and quality of life. As per WHO, it is a set of measures that assist individuals who experience and are likely to experience disability to achieve and maintain optimal functioning in interaction with their environments. So the purpose of rehabilitation is to help the patient decrease the impairment as well as possible and to minimize the disability and handicap amongst the person. Its purpose is also to accelerate the process of regaining functional abilities. Like I talk of the robotic things, they can really accelerate the process of regaining the motor power in these patients. So rehabilitation is all about restoring the ability to do something, making the person as far as possible, increasing the ability to sit, ability to stand, ability to walk, ability to communicate, eat, and doing all the day-to-day activities of the person. It's a kind of similar to the well-known serenity prayer, wherein it is said that God, give me strength to change the things which can be changed. Give me grace to accept serenity, the things that cannot be changed, and give me wisdom to distinguish the one from others. So at that time, the person just think at least some power I can have after having been undergone such a severe disability in one's life. So the goal of rehabilitation is to make the person physical independence. Again, it depends. Once we talk of the function, it again, the word meaning of function is different for different individual. It can be different for a person who is young enough. It could be different for a person who's female. It could be different for a person who is quite elderly. Like the elderly person can have the physical independence that I should be able to carry on my activities of daily living. Then it could be social integration. The person should have the ability, young person, that I should be able to go back to the society. I should be able to move. I should be able to do at least some occupational integrations, depending upon if the person is young enough and the patient is survivor of head injury, the person might be given certain occupational therapies so that he's able to live his activities of daily living, and definitely the psychological support to these patients. It is very important to start the rehabilitation in the early stage. Once the patient, even though comatose patient in the hospitalized, even though the patient is on ventilator. So if we start, if there is an early input from the rehabilitation, it has shown to have positive effect outcome on the patients as per the length of the stay of the patients, duration of rehabilitation, like the number of months or years which are required to make the patient independent, duration can be decreased and improve the functional status at the time of discharge from the hospital. So as soon as the person is admitted in the hospital, is stabilized, immediately we need to start with certain rehabilitation measures. So in the early acute rehabilitation, the main goal at this stage is preventing the complications related to immobility. Talking of the passive range of motion exercises, because the patient might be at that time totally dependent upon the other healthcare professionals or the caregivers, or even positioning, helping the patient to sit in the semi-sitting positions, There are certain sensory and proprioceptive stimulations which can be started in the hospital itself. This is called the coma arousal therapy or the coma stimulation, which involves promoting, awakening, maintaining arousal, and enhancing the rehabilitative potential of comatose patients by stimulating all the 5 senses, including visually, olfactory, gustatory, tactile, peripheral, central, auditory, and kinesthetic stimulation. We carried out this study by one of our master students that is under publication, wherein we saw the effect of coma arousal therapy, and it was quite effective in decreasing the duration of hospitalization and in improving the consciousness level of the patients. I will not be able to share the results because it is still under publication. So the various coma arousal therapy is simple measures. Once we are talking to the patients, once we are caring the patient in the hospital, we can always carry out these types of measures. For example, for the visual, this is stimulation of the eyes with the bright eye. Once we'll be bringing out the light from one side. Once we'll be doing it for one eye, then we'll be going to the second eye. Similarly, for the olfactory, we can make use of the perfume swabs. We can take out take the perfume swabs to one nostrils, closing the other nostrils, and then repeating on the other nostrils. Similarly, we can go for the tactile stimulation wherein we can gently touch all the 4 limbs with certain cotton swabs, or maybe even with your fingers. Small gently touch can be given to the patients going from the peripheral to the central side. Then giving certain peripheral stimulation wherein we can give painful stimuli at the nail beds of the patients. For the auditory, as per the choice of from the caregivers, we can always ask them what is the choice of music for the patient. So we can always go for a specific type of music, or we can have certain recordings from the patient's caregivers, like it can be of the kids, it can be of wife, it can be of parents, which can be given to the patients to be heard with certain earphones or so. They are also quite helpful, and definitely making use of the kinesthetics, including range of motion exercises. So these are small measures which can really help the patient in increasing the consciousness level of the patients. Various range of motion exercises, again, it can be passive, it can be active exercises, active assistive exercises, registered exercises, which can be manual or mechanical, or we can make use of isometric or the muscle strengthening exercises. There are certain principles which we need to keep in mind, that the patient should be completely rested, patient should be comfortable, and should be pain-free to gain cooperation from the patients. Because for the unconscious, we will not be able to understand whether the patient is in pain or not. So definitely we should give certain pain medication before we start with these exercises. Position the patient in, there should be proper body alignment and drape as necessary to avoid undue exposure of the patients. Maintain good posture to ensure efficient body movement. We should always face the patient to observe the facial reaction to the exercises. All the movement should be very slow, smooth, and rhythmic movements. And to move the body part to the point of pain resistance. If we are feeling certain resistance, or the patient is experiencing still pain, we need to stop there, and gradually we can increase the angle. And if the patient becomes excessively fatigued, we need to discontinue. The passive exercises, we know that these are the smooth, rhythmic, and accurate anatomical movement which are performed by the therapist within the pain-limited range, as the patient is totally dependent upon the caregivers or the other healthcare professionals. For the active exercises, these are the exercises which are performed by the patient himself without assistance and resistance by the external force. This can be done in the later stage once the person is out from the acute phase of rehabilitation. Active assisted exercises, these are the range of motion exercises to a body or a joint, which is accomplished by the patient with certain assistance of another person's. Registered exercises, these can be manual registered exercises wherein the therapist is giving certain resistance to the person. It can be mechanical registered exercises wherein the mechanical devices are used to oppose the active movement of a person. For example, it can be weight, it can be pulleys, and these exercises are definitely in the later stage once the person is quite independent enough to carry out the exercises. So these are the isometric or the muscle strengthening exercises which are accomplished by alternating, tightening, and relaxing the muscles without the joint movements. So these exercises, they really help in building the muscles of the patients. So these are the traditional exercises, but are very, very important in the acute stage. And there are certain new advancements, which I'll be talking about in the next part of my presentation. So we know that there is a large proliferation of technological approaches for the human rehabilitation, which have enhanced the intensity and quality of neurorehabilitations. So we can make use of robotics assisted training, constraint induced movement therapy, mirror therapy, functional electrostimulation, virtual reality, and non-invasive brain stimulation, which includes the repetitive transcranial magnetic stimulation and transcranial direct current stimulation, and body weight supports to treadmill training. Talking about the robotic devices, robots for neurorehabilitation are designed to support the administration of physical exercises to the upper or lower extremities. Herein, the purpose is to promote the neuromotor recovery at an early stage. It relieves strenuous repetitive efforts which are to be done by the therapist. Second, I was talking about is the CIMT. Here it's the underlying concept of CIMT is restricting the use of unaffected upper extremity by a mitten or sling. Here you can see that this is the normal limb of the person which is restrained, and we are helping the other person's the affected extremity to be used. So forcing an individual to use the affected limb to complete the task-based activities affecting the neuroplastic change and improving the upper extremity function over time. So it is done mainly for the training of the upper extremity, and the important thing is that there should be normal upper limb is so here in another important point is that the normal upper limb should be constrained for about 90% time of the awakening time, not the once the person is sleeping. And the important thing we need to keep in mind that the person should be having some wrist and finger function before starting of the affected limb. Otherwise, it will be very, very difficult. So there should be some function of the affected limb before we move on for the CIMT. And there should also be absence of cognitive impairment, excessive spasticity, or the impaired balance in these patients. The number of studies have been carried out for the effectiveness of CIMT. And it has been shown that the CIMT appeared to be more effective at improving the arm movement than active physiotherapy treatment or no treatment at all. Next is the mental imagery or the mirror therapy. It is a form of motor imagery in which the mirror is used to convey visual stimuli to the brain through observation of one's unaffected body part as it carries out a set of movements. So from the mirror therapy, from the name itself, it should be clear that herein we are making use of a mirror from where the person is moving the normal limb, and the image is being carried on the patient's mind that he is moving his from the mirror, that the person is thinking that he is moving his the affected limb. So that message is being sent to the brain of the person. That really helps in improving the motor power of the affected limb. Of course, a lot of time is required for such type of interventions to see the effect of interventions. So the underlying principle is that movement of the affected limb can be stimulated by visual cues originating from the opposite side of the body. It enhances the recovery by enlisting direct visual stimulation, showing the affected limb working properly rather than relying on the mental imagery alone. So this is better evidence for use to improve the upper limb functions. Definitely it can be made use for the lower limb also, and definitely it should be used along with the other type of therapies for the patients. This is again one of the intervention which has been published in Cochrane Library, wherein it has been shown that it has been proven that the mirror therapy was quite effective in improving the limb functions after the stroke. This is another common therapy which is being used in majority of the hospitals. This is the functional electrical stimulation. It is the most promising technique for hemiparetic arm. It involves wherein the denervated skeletal muscles and innervated muscles that cannot be contracted voluntarily can be stimulated electrically to help alleviate or prevent disuse, atrophy, and muscle spasticity. So it is used as neuroprosthesis, and it is a functional aid for performing the activities of daily living and can aid the motor recovery of the patients. Virtual rehabilitation again is very, very important. We are computer-based technology, which involves the stimulation of an environment with which the patient can interact. So it can be immersive therapy, virtual VR, or it can be non-immersive VR. What is being done in the immersive VR system, it makes use of large screen projections or head-mounted displays or cave systems and or video captured systems to immerse the user in a virtual reality. Really, जिसको हम कहते हैं कि person is experience the real situation, that he is able to move his limbs, he's able to moves his arms or the hands. So actually that particular thing the person is experiencing while immersing in the immersive VR system. In contrast, in non-immersive VR system, it is simply making use of a computer screen to stimulate an experience with or without interface devices. Another technique is non-invasive brain stimulation. In non-invasive brain stimulation, there is an involvement of the application of weak electrical or magnetic fields to the brain via the surface of the scalp with the goal of changing or normalizing the brain activity. The non-invasive brain stimulation modulates brain excitability and functional plasticity with relatively safety and facilitate motor learning when combined with the motor task. So this is just the schematic representation of non-invasive brain stimulation technique for facilitating motor recovery after stroke. Another is the transcranial direct current stimulation, TDCS. It is another non-invasive technique for stimulating the cortex of the brain. It involves passing a low current between two electrodes on the scalp for 10 to 30 minutes. So the underlying neurons, they are polarized and become excitable. This is again one of the study wherein this intervention was carried out and was shown to be quite effective in improving the outcome after stroke. Learning problem is quite a lot amongst these patients, as I told you, and I have seen certain patients that they really go back in their childhood. So we need to teach them even how to feed themselves, how to bathe, how to carry out the activities of daily living. So errorless learning is another important aspect which can really help in these patients. In this method, the correct response is provided immediately to avoid errors. Correct response, for example, the person is asking, person has forgotten the name of his wife or the kids. So the correct response, we can immediately say that this is the name of his wife, this is the name of the kids, or any relationship, anything. So immediately we need to correct the person. Then the cues and assistance are gradually faded. Initially we can give certain cues, but gradually those cues are to be faded and the patient are to be motivated to remember the name of those persons. So these exercises are always structured to prevent the patient from making errors. This is because errors are thought to create cognitive barriers such as interference with acquisition, emotional barriers such as frustration, and behavioral barriers such as avoidance. अगर नहीं होगा तो बाद में patient को frustration होगी कि मेरे को नहीं करनी है ये activity. Errorless learning is best suited for the patients with TBI who lack declarative memory, for example, naming the dates, the relationship, or the names of the persons, the day, etc. Even in cases of persistent functional deficit, 10 years after TBI, it can still be effective for improving the personal and instrumental activities of daily living. Another important we see in these patients is on bowel and bladder incontinence, and it has been estimated that 62% of the patients with a TBI will report urinary incontinence and 68% will report fecal incontinence. So we can just think of that how difficult and frustrating for the patients these types of deficits. And at 6 months post-injury, 18% will continue to report urinary incontinence, and at 1 year, 5% will continue to report the fecal incontinence. These conditions can increase social isolation and can negatively impact the psychological well-being of the patients. So bowel and bladder education is an essential component of an acute rehabilitation program and helps prepare individuals and their families for the transition back into the community. So it's very important to go for the behavioral training for the bladder as well as for the bowel as well as for the bladder. 3 primary components include education, schedule voiding, and positive reinforcement. So the patients need to be educated to understand the physiology, pathophysiology, technique, and desired outcome. So definitely here, the inclusion criteria is that the patient should be able to little bit understand about all these parameters. So we need to monitor the person. The person is checked by caregivers on a regular basis. that after every 2 hours, 1.5 hours, depending upon that what should be the voiding frequency, we can always monitor the person. Then prompting, asking the person to try to use the bathroom to void, and praising the person for maintaining continence and attempting to use the toilet. So whatever techniques we are making use of for our kids, we need to make use of all these activities for the patients who are survivors of head injuries. Pelvic muscle exercises, including Kegel's exercises, they have also been proven to be quite beneficial in these patients. So here, basically what we have to tell the patient to contract to a count of 10 and then relax to count of 10, the pubococcygeal muscles. And about 50 to 100 of these exercises must be done daily to be effective, and it takes around 4 to 6 weeks to notice the improvement. So here in basically these types of exercises, they strengthen they strengthen the periurethral and the pelvic muscles in the women. Bowel incontinence, similarly, we need to manage the regime that includes the timed elimination. Herein, we can always see maybe if the person is in the habit of passing the stool once in a day. So we need to note down exactly the timing, that what should be the ideal time, what should be the time for the persons to void. So we need to maintain the routine for the persons, and at that time we can make use of certain interventions. For example, if the person is able to is able to go to the toilet, we can always ask the person to sit on the toilet seat and can keep a small stool under the foot of the persons, and we can give a squatting position to the patient. That also really helps for the person to for the bowel habits. Communication is also again very, very important, because sometimes the persons they are not able to speak out. Aphasia patients are there, so we need to carry out certain interventions. Again, these types of communication charts we can make use of. This is again one of the chart which was prepared by one of our master's student. So from the pictures, the person can point out towards a particular thing depending upon the need, and accordingly the intervention or the need of the person can be fulfilled. So this involves the basic needs as well as the advanced needs. And so here you can see a nurse using the communication chart, and quality of care really improves when a reciprocal communication relationship develops between the patient and the nurse. Speech therapy, we can always go for consultation from the institutions. There could be auditory training, lip reading. We can always make use of, or we can make use of various signboards for the communication. Dysphagia is another problem in these patients, because TBI patients have neurological impairments affecting all the phases of swallowing, and lack of cognitive processes critical to a normal swallow. So abnormal muscle tone, reflexes, and sensory deficit all contribute to swallowing impairment in these patients. And because of this, aspiration is the biggest risk for these patients. So there are certain glottis exercises or the swallowing exercises which can be made use of. Again, here will be that the patient should be able to follow your instructions. Patient should be conscious to carry out these types of exercise. And till then, we can make use of other types of intervention of the interventions or the therapies to improve the intake of the persons, as Manju has already explained. Various types of routes for giving the good nutrition to the patients. So in this maneuver, what we are asking the patient to place the tip of their tongue between the front teeth or the gums and then to swallow. So they will be these types of exercises help improving the swallowing reflex of the patients. So the take-home message is rehabilitation is the team approach. It is not the work of the physiotherapist or the doctors. It is a team approach wherein the physiotherapist, the neurosurgeon, the nurses, the psychiatrist, and the psychologist, they should work together as a team in order to improve the quality of life of the patients. We need to make use of various evidence-based approaches to improve the rehabilitation, to bring the person back to the community. And early mobilization is very, very important in these patients. Early rehabilitation is very, very important in these patients. We need to motivate the person, even if the person is, even if there is a 1%, 2% improvement in the condition of the patient. Motivation really will help the person to come back to the normal level. And we should always involve the person as far as possible, depending upon the capacity or the capability of the person to be involved in the rehabilitation processes or the exercises. So in the end, I just want to say that no brain injury is too mild to be ignored or too severe to lose the hope कि कुछ नहीं हो सकता है. We should always try our level best to improve the quality of life of the person. And March is the Brain Injury Awareness Month. We should always try to make the people aware to avoid TBI as far as possible. Thank you so much for patient listening.
Thank you, ma'am, for such an elaborate presentation on rehabilitation of the patients with traumatic brain injury. Now we have come to the last session of today's workshop that will be presented by Dr. Kartigan. He is Associate Professor, Department of Neurosurgery, PGIMER, Chandigarh. He is going to touch again a very important part of traumatic brain injury, that is TBI among children. Over to you, sir.
Can you see my screen, Latika?
Not yet, sir.
Can you see my slides?
Not yet, sir. So kindly share your screen. Sir? Dr. Kartigan? Kartigan, you have an option at the bottom of your screen. You can share the slides with that.
Yes, can you see my slides now? No.
No, sir.
Just hold on, just a minute.
So yes, sir. Now we can see your slides.
Okay.
Go to first slide and kindly put your slides in the slideshow. Yes, sir. It's visible.
Okay. Am I audible?
Yes, sir. You are audible.
Okay. Good afternoon, everyone. Thank you for the invitation, Latika. So in the last 2 days, the previous speakers have covered almost all aspects of TBI. So like in this talk, let me try to briefly talk about certain aspects which are very specific to brain injury in children. So just to know the impact of the TBI in children. So they are TBI, the leading cause of morbidity and mortality in children more than 1 year. So in some Western countries, the impact is so much that the death due to TBI is almost 18 times more when compared to other pediatric brain tumors. This is data from Center for Disease Prevention and Control, which says approximately 4 million children in US suffer TBI annually. And in our setup, I mean, almost 20% of injuries what we see in our trauma center occur in children. And there is a bimodal distribution which is normally seen in TBI in pediatric age group. One in less than 2 to 3 years, and the other peak in adolescence. So children, children head injuries are not same as adults. So children are not little adults. So there are certain anatomic and physiological features which distinguish them from adults, and so they are considered as a special group of the special subset. So how are they different? With respect to TBI, in children, the way we approach children with TBI, the method we examine them, the patterns of injuries, the management aspects, and the specific imaging patterns and the prognosis all are different from that seen in adults. So just coming to how these children differ from adults. The first thing is children have a large head when compared to like body, which make them more vulnerable to traumatic brain injuries. From the physiological aspects, in a younger child, the brain contains more water content, and it is less myelinated. So like any brain tissue which is less myelinated is less likely to absorb the trauma forces, and these children are more likely to suffer acceleration or deceleration injuries compared to adults. And again, the skull in children are not well developed. They are very malleable, and they are easily compressible. So there is more chance of coup and contra coup injury. By contra coup injuries, we mean that occurs exactly at sites opposite to the site of impact. And again, the calvarium, the skull is very thin, and with open fontanelles and sutures. I'll just come to this later when we talk about the imaging aspects. And in young children, the air sinuses are not well developed. So when the sinuses are fully developed, the major impact, at least a significant impact to the head is taken by these sinuses. Because these are not well developed, the head takes a major impact, and this makes them more susceptible to brain injuries. And then children, as I said earlier, they have a large head with a weak torso neck muscles. So the major force is at the upper cervical spine. That is, this acts as a sort of fulcrum, and upper cervical spine injuries are more common when compared to adults. And one of the most important aspect is these children, especially the younger ones, say less than 2 to 3 years, they have a thin scalp, and small bleeding into this scalp can cause significant hematomas that we have seen. Even the scalp hematomas are one of the major cause for hypertension in these young children. So coming to the injury mechanism, overall what we see in our setup is the most common injury mechanism is falls. Either they are, most commonly they fall from height. But Western data and other data says in less than 4 years, falls are the major cause. And in less than 1 year, especially, child abusive injuries are a significant cause etiology in this group. And as they grow older in adolescent age group, RTA becomes a major cause of injury. So these have been already covered by Dr. Dandapani yesterday, the basics of airway breathing and circulation. So once that is taken care of, next we come to assessment of neurological status by the GCS. I'll just talk about in the next slide. And one specific thing which you need to look in children, especially less than 1 year, is the status of the anterior fontanelle. Anterofontanal, like, is normally it's open, and about 12 to 18 months, like, it closes. So in a child who is less than 1.5 years old, always look for the fontanel, see if it's bulging or it's flat. Bulging fontanel is indicative of a underlying raised intracranial pressure in these children. So the GCS in children, they are slightly modified when compared to adults. So this is like pediatric version of GCS. The main difference is that is in the verbal response. The motor and the eye opening commands remain the same. And as you can understand, like in young children, it's difficult to examine the orientation of time, time, place, and person. So this is replaced by certain aspects, like if the child can smile or coo or like babble, which is appropriate for the for his or her age. So that is given a like score of 5, which is normal. And again, if the child cries to painful stimulus and the cry is consolable, then it's considered as 4. And if the cry is inconsolable, then read as 3. And a child which grunts or agitated to a painful stimulus, then we grade it as 2. And when there's no response, it's 1. So this pediatric GCS, like, is mainly applicable for children who are less than 5 years, and even in less than 5 years, there is a difference in assessment between children who are less than 2 years and who are between 2 to 5 years of age. So like most of the injuries we see in children are mild head injuries. That is more than 60 to 80% belong to mild injuries, and the most common manifestation of mild head injuries is concussion. So what is concussion? It's defined as a clinical syndrome of biomechanically induced alteration of brain function, typically affecting the memory and orientation. This may or may not involve loss of consciousness. So loss of consciousness is not a prerequisite to term someone having a concussion. The CDC defines concussion as an acute brain injury with, which is due to some external physical forces, with one or more of the following criteria. After an impact, the child can have confusion and disorientation, or can have a loss of LOC, which is about for 30 minutes, or the child can have post-traumatic amnesia, which is transient, and these recover over 24 hours. Or if the child has a GCS of 13 to 15 after, between 13 to 15 after half an hour of injury, then it fits into the criteria for confusion. So this, as I said, the child can present in a number of ways, ranging from simple confusion or loss of consciousness or some mild memory disturbances, or they can have post-traumatic seizures or just like vacant stare look. But there are many concussion assessment scales which are in use. Like, I'll not go into details of all this. I would like to mention certain specific imaging features which are unique to children and that is not commonly seen in adults. Like in adults, you can see a spectrum of injuries ranging from extradural hematomas, subdural hematomas, parenchymal injuries in the form of contusions, traumatic subarachnoid hemorrhage, or overlying skull fractures, even in children. But there are these are some injuries which are specific to children. As I said earlier, in young children, the sutures are open, and sometimes you may face a difficulty in differentiating a fracture from a normal suture line. So how to differentiate between these two? A fracture line is normally, you can see the arrow here. The fracture line is normally a linear one, and when you look at the suture lines, they are serrated and they have sclerotic margins. and there are some conditions which are known as sutural diastasis. These are fractures which involves the suture line in a infants. I mean, after injury, the suture lines, I mean, the fracture occurs along the line of suture lines, and the suture tend to, I mean, wide open. And ping pong fractures, again, these are very specific to children. As I said initially, the skull is more malleable. So after an impact, you don't see a fracture line like you see in adults. Rather, the skull tends to like indent and like it's tend to sort of buckle inside. So this is known as ping pong fractures. And again, this is like I mean, one of the conditions seen in children less than 2 to 3 years, growing skull fractures. These are known by a variety of names. Most commonly, they are also referred to as leptomeningeal cyst. These occur whenever a child sustains fracture with underlying dural injuries. So, like over a period of time, say in months, because there is an underlying dural injury with fracture, the underlying brain, because of CSF pulsations, tend to come out and they slowly expand the fracture lines. So that's why this particular entity is known as a growing skull fractures. And diffuse cerebral edema, and again this is like more common in children compared to adults. Yeah, a number of mechanisms have been implicated in the I mean in the pathogenesis of diffuse cerebral edema. Like one is, compared to adults, children have a less relatively, you know, developed auto-regulation mechanisms. So the cerebral perfusion pressure, cerebral perfusion pressure increases. I mean, and there is cerebral hyperemia, which predisposes to this sort of injury. And if you see the scan, the entire brain becomes edematous with loss of sulci gyrus, and there is loss of gray and white matter differentiation. And if you see the systems, they are basal systems, they are all obliterated. Most of these cases, they require just a conservative management with decongestions like mannitol or hypertonic saline and ventilation. Next we come to abusive head trauma. These are known by a number of terms. These are basically inflicted TBIs. Like common term, these are known as like shaken baby syndromes. This is the I mean, these are injuries which are inflicted by adults due to violent shaking. I mean, which causes a sudden acceleration and deceleration forces. And these causes the veins to rupture. The cortical veins which are present rupture, and I mean, and they cause intracranial bleed. And this children is commonly seen in children which are less than 2 years of age. There are specific definitions. I mean, by the American Academy of Pediatrics, which define this condition as a constellation of cerebral, spinal, and renal injuries that result from inflicted head injury to infants and young children. These are quite recognized in Western countries, but like probably like under recognized in I mean our Indian scenarios. I mean, again, the child can present with a number of manifestations, right from hypothermia and excessive behavioral disturbances, increased ICP due to bleed, seizures, vomiting. And whenever we examine these children, there are some red flag signs which indicate that the underlying injury could be a abusive head trauma. One, the history which is given by the like attempters, they are either inconsistent or they are changing. And again, when you look at the history, I mean, the amount of injury versus the history given does not like correlate. And these children, they don't have obvious external injuries, which which indicates otherwise normal trauma. And one should always look for other physical signs like multiple bruises, because it's a chronic repetitive trauma. They can have bruises at various stages of healing, and always look for other skeletal fractures, more commonly rib fractures and other long bone fractures. There are some specific imaging features which point towards abusive head trauma in children. The most commonly, when you get CT scans in these kids, you can see the subdural bleeds. These subdural bleeds are at different stages. As you can see here, this is hyperdense, and this is dark. This indicates that the bleed has occurred in various stages, which obviously indicates a repetitive trauma which is happening to the kids. And the classic feature in these kids are bilateral retinal hemorrhages. So whenever you suspect, always look for fundus for bilateral hemorrhages, and as I said earlier, always look for other evidence of fractures, especially ribs and long bones. Okay, the next important issue consideration in children is imaging in pediatric TBI. As in adults, it's not wise to get CT in every children who walks to casualty with some sort of history of neurotrauma. What are the issues in getting CT in these children? The major issue is you are exposing the child to unnecessary ionizing radiations. Though the absolute risk may be small, say risk of malignancy may be 1 in 1,000 scans obtained. But considering the huge patient load we have, when we don't follow certain algorithms, you are more likely to expose these kids to unwarranted CT scans. So studies have come up with certain clinical decision rules, like algorithms, which indicate that a particular child is more likely to have injuries, and again certain features which are less in favor of intracranial injuries and which are not required. Say for example, I'll just try to give an example. A patient walks to a trauma OPD after trauma with just say some trivial trauma and a single episode of vomiting. The normal tendency would be to go for some CT scan. Even practice. Even we also practice the same thing here. But in these sort of trivial injuries, CT scans are not necessary, because studies have shown less than 5% of such kids actually have significant intracranial injuries, and less than 1% have. Less than 1% of these kids need any surgical intervention. So there are some major decision rules which are proposed. These are the most popular ones: Pacan, Chalice, and Catch algorithms. You can, these are widely available, and you can just go through all this. I will just try to emphasize upon certain indications based on NICE guidelines from UK. So these guidelines indicate we have to go for CT scan in a kid. Whenever you suspect non-accidental injuries, as I said earlier, or if the child has post-traumatic seizures, and if the GCS is less than 14, or in an infant, if the GCS is, any GCS less than 15, you have to go for CT scan. And always look for signs of injury, such as open or depressed fractures of skull, and signs of skull basal skull fractures. These can be black eyes, CSF rhinorias, CSF arterias, and bruising behind the mastoids, which are commonly known as battle signs. Or if the child has got any focal neurological deficits like hemiparesis, cranial nerve deficits, or any obvious signs of external injuries. So if any of these risk factors are present, like it's advised we get a like CT within less than 1 hour. So the other set of criteria which they discuss is if any of if more than one of the following criteria which I mentioned, like LOC more than 5 minutes, or if the child is abnormally like drowsy, or there are recurrent vomiting episodes, and or if the mechanism of injury is high impact velocity injuries, or if there is a like amnesia which lasts more than 5 minutes, then a CT scan is indicated. Okay. Next, I will just quickly touch upon certain recommendations in the management aspects of TBA. I think this adult guidelines have been discussed already. So these are like certain best practices which are put forth by brain trauma foundations based on certain level of evidence. So like level 1 evidence is based on high quality studies. Level 2 is based on like moderate quality studies, and level 3 is low quality studies. Uh, like concern to TB in children, they advise intracranial pressure monitoring in children, and they have seen the outcomes have improved after ICP monitoring, and certain advanced measures like brain tissue oxygenation have been advised in these kids. And while managing like patients with head injury, like in children, your like target ICP has to be like less than 20 mm of mercury, and try to maintain the cerebral perfusion pressure to at least like 40 millimeters of mercury. And again, regarding osmotics and childhood brain injuries, the traditionally like we use mannitol, but the recent interest is on hypertonic saline, most commonly 3% saline, which is being used, and in some studies even higher concentration of 23.4% hypertonic saline are also being recommended. And again, this is a controversial issue. So the recent guidelines says that hypertonic saline is better than mannitol. There are some prospective studies even from our own setup, like which says that both are equally effective, and it's left to the like choice of the treating physician and healthcare workers. And prophylactic hypothermia is not indicated in pediatric brain injuries, but a moderate amount for raised ICP, between 32 to 30 degrees are recommended for ICP control. And Brain Trauma Foundation guidelines, they advise barbiturates for ICP control in children. And when there is refractory ICPs, decompressive craniectomy is an option, and it has shown some better outcome. And regarding seizure prophylaxis, as you all know, any seizure which occurs less than 1 week of post-injury is known as early post-traumatic seizures. And seizure prophylaxis in children, they have been identified to reduce the occurrence of early post-traumatic seizures in children. And as ma'am discussed, it's always preferable to start early enteral nutrition, as early as possible, say within 100 hours of injury. And this has shown to decrease the morbidity and improve the outcomes. Shortly, I'll just tell about prognosis in these children. I'll just try to focus on mild injuries because these are the most common injuries which we see. As healthcare professionals, we should know that almost more than 3/4 of these children with mild injuries, like over a period of like 1 to 3 months, they improve significantly. And we should always be aware of certain factors which can delay the recuperation in these kids. Like recovery might be delayed in children who already have like premorbid like illness, or who has developmental or psychiatric disorders, and who has a larger extent of symptoms after like injuries, and other like family and social stresses which can delay the recovery in these kids. And what about physical rest and resuming the normal activities? The resuming of normal activities have to be like gradual. Basically, we have to discuss with the like families and persons. So like go slow, and if they're able to tolerate their normal activities, and they don't have any recurrence of symptoms, post concussion symptoms, then slowly they can get back to their normal activities. Return to school again, uh, it's a group decision which is based on some family and on the individual side, and this is individual. And this is like individual decision based on which varies with each kid. So the like, take-home message, which thing is, children are a different subset. Don't extrapolate things which are aspects which are studied in adults to children. Most children have mild injuries, and the outcome is really good. Whenever you have a suspicion, always think of non-accidental traumas, and be cautious, and apply your clinical as well as clinical decisions for getting a like CT scan in these children. Thank you very much.
Thank you so much, sir, for highlighting the TBI among children. Now we have got two questions from the participants. The first question is from Dr. Manju Dandapani. Ma'am, are you here?
Hello, Latika.
Yes, ma'am, we have got a
Can you hear me?
question for you, ma'am.
Yeah, please tell me.
Ma'am, there's a question that how to calculate BMI based on knee length.
Yeah, actually, it's a good question, because for nutritional management, we need to assess the height of the patient, then only we'll be able to know the weight of the patient. There are different methods of checking height of the patient, because we know that when the patient is on bedridden status, we cannot make the patient to stand and measure the height. So there are various measures there is one formula is based on the knee length. And then there are various other nomograms also when to calculate directly the weight based on the waist circumferences, hip circumferences, and height. So here, how we calculate, I'll share my screen. So it's a formula. It will be better if I share the screen. It will be easy for you to understand. So is it visible?
Not yet, ma'am. Yes, ma'am, it's visible, ma'am.
Yeah. Yeah, this is the formula which you can see here. To calculate in males, there are two formulas. This is in males. If you want to exactly calculate based on the age, if it is 37, 38, then if we are bringing the age also into calculation, this is the formula for males and females separate. And if you want to have a range of for a weight for a height for a range of age group, then we have another formula which was developed and verified in 1994 by Chumli. So this is knee length into 1.88 plus 71.85. So these are the formulas which we can use for calculating the height of the patient. And there are even other methods now are coming in. Now recently one study showed that even if you straighten the patient and make the patient to lie down supine and head to toe, if you measure the height, that also is having good reliability. But initially when I was doing this study, that time it was the study whichever I went across was showing that directly measuring the height from head to toe, it's not accurate in a bedridden patient. But recently I read one article even like that, it is accurate. And based on the height, then we can calculate the height and weight, and then we can calculate the nutritional requirement of the patient. Thank you.
Even nowadays, beds are also available, which are giving us the weight of the patients.
Yes. Beds directly we can, there are weighing machines that was available since long time only. And also we can, there are some devices in which we can lift the patient and check the weight directly. So various innovative technologies are coming up. So
we have got another question. Significance of zinc in TBI patients.
in TBI patients. Yeah, zinc
Significance of zinc.
supplements. Yeah, there are many studies. Many trials have shown that zinc is important in improving clinical outcome in terms of GCS, reducing infection, and in towards a favorable outcome. Even after I did in AIMS my thesis, after 2 years, the many studies were continued on the same aspect. So zinc supplementation was given, and it was showing reduced level of infection in these patients. So this gives.
Thank you so much. Ma'am, we have another question for Dr. Mona Lisa. Ma'am, are you here? Dr. Mona Lisa, ma'am, are you here? We have got a question that what is the minimum time gap which is required between two neurological examination while declaring the brain death? I think this question was being answered by Mona Lisa ma'am already in her presentation, that at least there should be a gap of 6 hours between two examinations. And another part of this question is, what is the significance of this time gap? So definitely we need a time gap so that after 6 hours when we are performing the examination, it will be a confirmatory, or we can say it's a confirmation that before declaring that the patient is brain dead. So this would be the best answer for this question. We have another question, that what is the role of nurse counselor in the hospital for the brain death? And I think this answer could be not better than Miss Renu Kumari. She is working as neurosurgery nurse counselor. I think she would be the best person to answer this question. Over to you, ma'am.
Thank you, Ma'am Nitika. So as I want to tell you that in our institute, there are transplant coordinators. They are posted for this particular area only. They are working as a organ transplant coordinator, and they are there to do the confirmatory test, and all the tests are done with them. And they are there with the team, with the neurosurgery team, where they discuss the test, and they perform all the things over here. Another thing is the most common this bed sore scale which we are using in our institute, that is the Braden scale. And one more question was there, like the cooling blankets. So yeah, we are using those blankets in our IC setup. I think thank you so much. Over to you, Latika ma'am.
Neuroscience nursing is a specialized branch in nursing. Nurses can minimize the treatment cost and improve the outcomes of the patients by providing best quality nursing care. It is high time that we strengthen the core of neuroscience nursing with regard to evidence-based practice and clinical intervention. This would be the best take-home message for all of us who all are working in the neurosurgical areas. Now, I take this opportunity to welcome Dr. Sukhpal Kaur, lecturer, National Institute of Nursing Education, PGIMER Chandigarh, to kindly propose vote of thanks. Over to you, ma'am. Due to some technical issues, ma'am is just about to connect with us. But yes, of course, we as neuro nurses, I want to emphasize again and again this thing, that the purpose of being here to be on this platform is that we can update ourselves with the latest practices, with the latest knowledge, so that we can implement into their areas. And the main objective of everything what we are doing in last day and today, what we are doing that you educate the nursing officers who are working in neurosurgical area. They should be updated so that when they are working in neuro areas, they work as nurse educators, not only as a clinical nurse but as a nurse educator, and they can educate the caregivers who are with the patients. And because these patients are in the long run at home, they need home care in the home care settings also, so they can act as nurse educators so that the caregivers can be trained, they can be skilled, they can be knowledgeable, and they can help their patients to recover back, to rehabilitate back to their normal lives. So this is what we have to make it sure that we inculcate this thing in us. And it's not only the one-day job, we can do it again and again. It's only what we can say is practice makes the man perfect. So how much we learn, how much we practice, we will learn better and better, and we will become a good and a better neuro nurse. The 2-day workshop is available on YouTube. It's available free of cost. Your friends, your groups, you can share the links, the YouTube links, and maximum people can watch whenever they are free. So just share these 2-day workshop with maximum people around yourself.
Am I audible?
Yes, ma'am, you are audible, ma'am.
Just a minute. Actually, current has gone, and just a minute. I'll sit and propose vote of thanks. I'm so sorry. Just in the end, the current gone. Am I audible now?
Yes, ma'am, you are audible, ma'am. Kindly, ma'am, you can show your photo.
Okay, this is from Sushma's mobile.
Yes, ma'am, you are visible, ma'am. Thank you so much, ma'am, for joining.
Yeah, thank you so much. And I'm so sorry in the end, the start was also like that. And in the end, the current has gone from 9. There is some technical problem. So it's my privilege to propose a vote of thanks to each one of you who was directly or indirectly part of this workshop. And at the outset, I would like to thank Professor S.K. Gupta, Head, Department of Neurosurgery, who graced the occasion as chief guest on the informal inauguration of the workshop. I also take this opportunity to thank Professor Amarjit Singh, Head Department of School of Public Health, and Professor Tiwari for gracing the occasion. I thank Dr. Karobi Das, Officiant Principal 9, for facilitating the occasion. My heartfelt thanks to all the guest faculty of Department of Neurosurgery and 9, Dr. S.S. Dandapani, Ms. Renu, Ms. Punita, Dr. Chandrasekhar, Dr. Manju Dandapani, Dr. Raghav Singla, Dr. Mona Lisa, Dr. Kartigan, for excellent deliberation. Thanks a lot for taking out time from your busy schedule. I thank the representatives of Telemedicine Department, PGIMER Chandigarh, for the technical help in smooth running of the program, and special thanks for working on the day of holiday. My special thanks to all the participants without whom we just cannot think of the success of the program. I'm sure you must have learned a lot from this 2 days program. Number of practical tips were given by all the speakers. I think majority of you are already working in neurosurgery units, and I wish you utilize the knowledge gained through this educational program and disseminate this knowledge with your colleagues. We are going to have the second session of this 2 days program again with the nursing officers who are left to attend this program. I congratulate Dr. Ms. Latika, going to be doctor for successful completion of the session 1 of this 2 days program. She had really worked very hard for the success to organize this program. Thanks a lot to each one of you once again. Thank you, Latika.
Thank you, ma'am, for motivating us all. Thank you, ma'am.
Thank
I
you.
think, ma'am, we can stop here.
Yeah. Can stop now.
Thank you so much, ma'am. Thank you, everyone, once again. Thank you, all participants, and all those who were directly or indirectly were part of this workshop. Thank you so much.